Good morning. Good morning, everyone, and welcome to this dissemination event of the PRIME Consortium. My name is Vikram Patel. I have been associated with PRIME ever since it began as its research director, and I'd like to welcome you all, and also especially our guests who've come from different parts of Britain to actually hear and participate in this program. First of all, I just also want to extend my apologies for the delayed start. It turns out that we had a problem, technical problem. I don't know if it's actually been fixed, but we're going to start anyway. So it turns out it hasn't been fixed, but hopefully it will be. I wanted to start by just giving a little bit of a historical backstory, as it were, to this consortium. Way back in 2017, many of you will remember the Lancet had published a series of articles. Some of us present in this room here were involved with that series. It was, I believe, the first time that the Lancet, which is an extremely prestigious medical journal, had devoted so much space on a subject that up until then was never really considered a legitimate subject for global health. And that was a series on what was then called international mental health, but soon emerged as the field of global mental health, a subject that really sought to connect the huge disparities in access to quality care for people with mental health problems within the broader discipline of global health. The series ended with a clarion call to scale up services for people living with mental health problems, particularly in low and middle income countries where the disparities were the greatest and where the suffering was enormous, and where there was a strong association between mental health problems and poverty. The year after that, in 2008, the World Health Organization, which had been very closely involved with the Lancet series, launched its flagship MHCPs program, which really sought to develop tools and methods through which the very large treatment gap for mental health problems could be bridged. And the first major tool it published was in the year 2010, the MHCPs Intervention Guide. Again, many of you were involved with this initiative. Graham Thornycroft, who's sitting here, was the chair of the Guidelines Development Group. And this guide sought to synthesize the massive evidence on effective interventions for the treatment of 8 groups of mental, neurological, and substance use disorders. But most importantly, the guide was really intended to be targeted to providers working in primary and secondary care settings. By definition, these were not mental health professionals. So now we had a guide that could be used in routine care settings that could treat a range of different mental health conditions. We had a clarion call to scale these interventions up in routine care settings around the world. What remained to be done was the implementation science to show how these interventions could be integrated in routine care in diverse contexts. Around the same time, Alan Flischer from the University of Cape Town was leading a DFID consortium called the Mental Health and Poverty Project in several African countries. And what this project was seeking to do, and ultimately demonstrated very compellingly, was a strong association between various kinds of deprivations, particularly poverty and gender disadvantage, with poor mental health. It was a bidirectional relationship. Living in conditions of disadvantage enhanced your risk of developing a mental health problem, and having a mental health problem enhanced your risk of suffering social and economic consequences that damaged your well-being. I think this historical backstory is extremely important to remember, because around that time, in about 2010 or 11, maybe 2010, DFID announced a new call of health RPCs, one of which was devoted to mental health. And I must acknowledge that it was incredible foresight of DFID to actually have a specific call for mental health, which was still then, to be fair, a pretty marginal subject in global health conversations. So Alan and I and Martin Prince and Kriklund began a conversation on how we could tie all of these different historical pieces together: the call to scale up, the evidence of effective interventions, the knowledge about the strong relationship between poverty and mental ill health. And so we put together an application that sought to scale up effective interventions in diverse contexts, and we were thrilled that we were able to attract interest from 5 low and middle income country investigating groups, each of which was led by amongst the leading investigators in global mental health from those countries, and you will hear from each of them later on this morning. Sadly, tragically, As we were putting the proposal together, Alan Fisher's life was cut short. He was going to be the CEO of Prime, but his life was cut short by cancer. And I remember Martin and me and Crick having furious discussions as we were grieving for his loss as to who might potentially take over that role. And we were clear that it was really important, not just symbolically, but in many other ways, that this RPC should be led from the south. And of course, Alan was from a southern university, the University of Cape Town, and we were thrilled and delighted that Crick agreed to take up the leadership role, very large shoes to fill, not least since Alan was in fact Crick's mentor. That was in May 2011, and that is when Prime began. Here we are now in March 2019, 8 years later, to hear about what this consortium has tried to do, what it has achieved, where it has fallen short, but most importantly, what are the lessons we can take away from 8 years of hard work across 5 different countries that can inform our understanding on how to integrate mental health care in routine healthcare settings. This morning, the program is going to be in 2 parts. The first part, which I will chair, will begin with a presentation by Crick Lund, giving us an overview of the story of Prime, 8 years of work in about 30 minutes. We're then going to hear from 2 policymakers from 2 countries who have been involved with Prime to hear about their perspectives. We're going to see a short video of user perspectives, people who have been beneficiaries of Prime-sponsored interventions. And then we're going to have a Q&A in the form of a panel discussion where you will all have opportunities to ask questions. So we won't have questions until we've completed the full range of presentations and the video. So with that, with those few opening remarks, I'd like to invite Crick Lund, the director, the CEO of Prime, to make his presentation.
Right, good morning everybody, and thank you Vikram for doing such a great job of setting the scene for today. It really is a great pleasure to be here, and really quite momentous for those of us who've been working for the last 8 years on this program to be at this point, to share our results, our findings, and some of our experiences. And there's been a lot of talk of the grand challenges in global mental health, and I have a grand challenge this morning, which is to try to summarize 8 years of work across 5 countries in about 30 minutes. So this is going to be necessarily quite superficial, but hopefully will give you a sense of what we've been doing. I'd like to begin by just acknowledging this remarkable team of Prime investigators and collaborators, really on whose behalf I'm speaking this morning. And in order to do that, I'd like to just ask if all the Prime members in the audience could just stand for a moment and you could all see who they are and where they're from. Please stand. Great, thank you very much indeed. So the purpose of Prime is to generate high-quality research on implementing and scaling up treatment programs for priority mental disorders in primary and maternal healthcare contexts in low-resource settings. So as Vikram has mentioned, there's been a real burgeoning of research in global mental health, particularly conducting randomized controlled trials to evaluate the effectiveness of interventions. So we now know a fair degree about what works, but we know a lot less about how these interventions can be delivered in routine, low-resource settings. And this was really the focus of our work in Prime. So the partnership was, as Vikram mentioned, set up as a Southern-led consortium, led from the Alan J. Fisher Center for Public Mental Health at the University of Cape Town. And we subcontracted leading academic research institutions and NGOs in each of the 5 countries. So you'll see, for example, from Ethiopia, it's the Addis Ababa University, led by Professor Abubakar Fikadu, and very importantly, a Ministry of Health partner in each of the countries as well. And this was a really important step when we began the grant. Was we had some seed funding from DFID to hold a meeting to actually develop our proposal, and we invited our Ministry of Health partners to that meeting, and they contributed to suggestions around the sites, around the particular research questions we should address, and how these were aligned with their particular policy priorities. And then in addition to the country partners, we have cross-country support partners in the form of the WHO, the Centre for Global Mental Health at the London School of Hygiene and Tropical Medicine and King's College London, Basic Needs, and great to see Chris Underhill here, and the Perinatal Mental Health Project led by Simon Honickman, who's also here today. And I think Vikram captured it very nicely here when he says the most exciting thing about PRIME is the fact that ministries of health in 5 countries and the WHO have joined mental health research leaders as equal partners. This is a picture from one of our annual meetings in 2015 in Madhya Pradesh in India. So our work is very much located within an understanding that mental health is an essential component of sustainable development. And one of our early outputs was to conduct a systematic review of interventions that might break the cycle of poverty and mental illness in low and middle income countries. And this was published as part of the second Lancet series on global mental health in 2011, really providing quite compelling evidence both for the effect of some poverty alleviation interventions like cash transfers on mental health outcomes, but very importantly for PRIME, showing that delivering mental health interventions leads to significant economic improvements, both at the individual and at the household level. So investing in primary mental health care is also a form of poverty alleviation and is a really important part of moves towards sustainable development. We conducted our research in 3 phases. Initially, an inception phase in which we conducted quite detailed formative qualitative research in each of the 5 district sites. There was 1 district site in each country. We then conducted situation analyses in each of these sites and developed a situation analysis tool, which we've now disseminated and has been used widely in other countries. And then in a collaborative way, we went about developing a mental health care plan for each of the district sites. So the district is really the unit of analysis for our work in PRIME. After that, we, in the second phase, went about implementing these mental health care plans in each of the 5 sites over a 2 to 3 year period, and evaluating the mental health care plan implementation using a number of different study designs, which I'll tell you about in a moment. And then, on the basis of those lessons and the tools that were developed, we went about scaling up these mental health care plans to other districts or expanding to other facilities within the initial district sites. So here's some pictures from the district sites. The Sodo district in Ethiopia in the top left-hand corner, the Kamuli district in the top right-hand and bottom left-hand corner, and the Sehor district in Madhya Pradesh state in India in the bottom right-hand corner. And we made a point every year when we met in each of the country sites to go and visit the district sites to really get a sense of how things were working on the ground. One of the important things that we did in the early stages was to conduct a series of theory of change workshops with stakeholders in each of the district sites. And for those of you who are not familiar with this method, it involves reaching consensus about the desired impact that a program hopes to achieve, and then setting out in a very clear and logical way the outcomes that are required along the causal pathway to achieve that impact. And what it does is it allows a group of individuals involved to pool their collective wisdom and experience, to design a program, to clarify the assumptions that you make about the causal pathway, but also very importantly to design a set of indicators that can be used to evaluate the implementation of the program. So it provides a tool both for developing the content of the interventions, but also to design your evaluation. And we've done a lot of work on theory of change on these workshops. These are some pictures from theory of change workshops in South Africa. And you can see members of the South African team involved in this. And it was really an essential part of it. And there have been a number of spin-offs from this, including one of our PhD students, Erica Broyo, who's the PRIME project manager, doing her whole PhD on the theory of change method and evaluating the data that came out of this. So this is an example. I know you're not going to be able to read all of this text, but an example of what a theory of change map looks like. It starts with the impacts, what we hope to achieve, and then works its way backwards in a logical sequence to clarify all the steps that are necessary to achieve that impact, beginning with the entry into the district. And so what we were able to do was to spell this out. This is a very generic, high-level theory of change, and much more detailed theory of change maps were developed for each of the country sites. But it helped us to clarify the assumptions, the particular functions of the mental health care plans, and then also the indicators to assess whether each of these outcomes were in fact achieved. And so one can then combine an evaluation that has elements of process evaluation with also outcome evaluation. So this is the broad structure of the mental health care plans that we subsequently went on to implement. And although the substance varied quite a bit across the different countries, they all followed this broad structure. They operate at 3 levels. First of all, the healthcare organization level. Secondly, the facility level, which includes both specialist services, which were actually quite rare in most districts, and largely primary healthcare facilities. And then, very importantly, the community level. And across each of these 3 levels, we implemented packages of care that included elements of raising awareness, improving detection of the priority conditions, improving access to treatment, recovery, and then a number of different enabling or systems level interventions that enable these services to be delivered. Sorry, I'm not sure where I should be putting this thing. So we then went about implementing this in 38 facilities, primary care facilities across the 5 country sites. And what you can see in this slide is the names of the different district sites, the population size, the number of facilities, and also in the end the number of visits during the implementation phase, around 20,000 mental health visits over this period. And I haven't yet mentioned, but the focus of our work was really on 4 priority conditions, which have a high level of public health burden, but also for which there are known cost-effective interventions. And these are depression, alcohol use disorders, psychosis, and then in 3 of the countries, epilepsy. So we really treated each of these district sites as a kind of laboratory in which we then evaluated the implementation through a number of different study designs. And Mary De Silva, who is in the audience today, led the design of these evaluations and included a number of different sub-studies. First of all, a situation analysis, which I mentioned before, and Charlotte Hanlon, who's in the audience, led the development of this tool. Secondly, repeat facility detection surveys to assess the extent to which primary care providers' capacity to detect common problems like depression and alcohol use disorders improved over time. So these were repeated over time. Thirdly, repeat community surveys to assess changes in population-level treatment coverage for depression and alcohol use disorders. Fourthly, we were really interested in not only the system-level impacts, but also the individual-level impacts of delivering these services. So we tracked cohorts of over 3,000 individuals living with depression, alcohol use disorders, psychosis, or epilepsy, and evaluated their clinical, their functioning, and their economic outcomes. And then finally, we conducted case studies, which are really evaluating the nuts and bolts of how the mental health care plans were delivered. So, for example, the number of training sessions that were delivered for the primary care providers, the number of supervision sessions, supply of essential psychotropic medication, the health management information systems, the actual delivery of the mental health care plans. So this is a broad overview of some of our preliminary outcomes. We've published the first outcomes just a few weeks ago from Nepal. So the Nepal country site outcomes are published and available in PLOS Med if you want to see those. And this is a necessarily crude summation of some of the main outcomes. Just to orientate you a little bit, the ticks indicate a significant positive improvement in the outcome of interest. The crosses indicate that there was no significant improvement in that outcome, and NA means the particular site did not conduct that particular sub-study. So what we see in summary is that although some countries, for example Ethiopia and Nepal, were able to show an improvement in treatment coverage at the population level, in most countries this is quite difficult to achieve. When it comes to the facility detection surveys, we saw in most countries that there was a significant improvement in the capacity of primary care workers to detect common problems like depression and alcohol use disorders, and this is through the repeat facility detection surveys that I mentioned. And then very encouragingly, in almost all the cohorts, in all the countries, once individuals were engaged in care, we saw a significant improvement both in their clinical and in their functioning outcomes. So the short message is, and people have already started to ask me, so what did you find after 8 years? You know, what's the elevator pitch? I think the short message is, once we're able to detect people and engage people in care, it is possible to deliver high-quality care that leads to a significant improvement in clinical and functioning outcomes using routine, low-resource primary care settings, which I think is a significant breakthrough. Typically, services have evaluated either specialist delivery or delivery in the context of randomized controlled trials. So these were very pragmatic, real-world situations. So some of the key lessons, first of all, it is feasible, it can be done, and we didn't have significant injection of new resources from ministries of health, but it is possible to deliver integrated primary mental health care services for these priority high-burden conditions. Secondly, participatory development of district mental health care plans is absolutely vital, and really engaging all the stakeholders involved, including NGOs, service user groups, the primary care staff who are expected to deliver the services, the district health management team, and also the higher level state or provincial and national players was absolutely vital in this process. Without their buy-in, their design, in fact, of the substance of the mental health care plans, this wouldn't have flown. And thirdly, a really key message, and this goes back to Vikram's comments about the MHCP intervention guide. We feel very strongly that training alone using the MHCP doesn't work. It's really the systems of supervision and ongoing support. It's the strengthening of health systems that enables these care packages to be delivered. And so it's vital if we are to scale up MHCP, and MHCP is now in over 100 countries around the world. If that is to be sustained, there needs to be also substantial injection of supervision and health system strengthening to make it possible. And I'm going to elaborate on each of these in a moment. And then fourthly, demand-side interventions are really vital. It's very important that we stimulate at the community level demand for mental health care services. We can't expect that just by improving the availability of services that they will necessarily be taken up. So I want to just say a few remarks, just elaborating on points 2, 3, and 4 here. Sorry, mainly on point 3 and 4, because I've spoken about theory of change already. The first one is about system strengthening. We're now taking this work forward through a National Institute for Health Research funded grant called Asset, Health System Strengthening in Sub-Saharan Africa, which is being led by Professor Martin Prince, who's in the audience today. And this is really focusing on a number of different areas, not just mental health, but includes mapping out care pathways and health management information systems, setting up quality improvement cycles, developing, very importantly, non-technical workforce skills like clinical communication skills, and developing person-centered care. And these are all critical components of what we believe makes it possible to deliver mental health in primary care settings. In fact, we have done quite a bit of work in Prime to develop these tools, and we made some quite important contributions to the WHO's MHCP operations manual, which was published in October last year and is now being used to support an MHCP implementation in the various countries in which that is happening. It's really an operations manual for district health management to help them to design and implement MHCP programs. And then in the South African team, through multiplier funding, Prof. Inge Peterson and her team have led a program called the Mental Health Integration Program, or MINT, and they have adapted this plan, prepare, provide approach to scale up the district mental health care plans in other provinces, including in Mpumalanga and KwaZulu-Natal, and that work is ongoing. Really not sure where to point this thing. Oh, there we go. Then secondly, I think it's really vital that we stimulate at the community level demand for mental health services. And I just wanted to flag two areas, and the country teams will be presenting more details of this later this morning. But in Nepal, Mark Jordan's and his team led the development of a community informant detection tool, which is used by female community health volunteers, community health workers living in the community, using case vignettes to identify people living with mental health problems and encouraging them to attend facilities at the primary care clinics. And then in Ethiopia, the team led the development of community case ascertainment methods to identify people living in the community with psychosis and then facilitating them to get access to care. Okay, so that's something about the mental health care plan implementation. I want to talk you through some of the other work that we've been doing in the background, because there's been a whole lot of other stuff happening with PRIME. And I want to share with you some of our PRIME numbers. So there's a different definition of PRIME numbers. So we've published already over 100 peer-reviewed journal articles, which I think is an amazing achievement from this group. 75 conference presentations, and then we've had a huge capacity building program as part of PRIME. We've had 20 PhD students linked to the work of PRIME, and I'm going to say a bit more about that in a moment. Secondly, the partnerships in this consortium have been really important, and Erika Breuer, who I mentioned earlier on, the PRIME project manager, has led this very nice paper published in Global Social Welfare describing how the partnerships actually functioned. And what you can see in this map, the thin blue lines connecting the different country sites are a collaboration on a peer-reviewed journal article. And this is the state of play in 2010, and this is the state of play in 2017. So you can see a massive proliferation, especially in South-South collaborations, to publish in scientific journals, which I think is just wonderful. Also, very importantly, we've done a lot of work on maternal mental health, and on your seats you should have this report, which summarizes some of our work in maternal mental health. Big thanks to Simone Honigman from the Perinatal Mental Health Project, who really drove and helped us coordinate a lot of this work. And you'll see it included a number of different areas, from the development of tools to the piloting of psychosocial interventions to assessment of needs for perinatal women in each of the district sites. In parallel with the work in the districts, we've also conducted a lot of work at the policy level nationally. And this has included contributions, for example, to the Ethiopian National Mental Health Strategy, which was the first such strategy published in 2012. In India, contributions to the new mental health policy in 2014. I'm not going to have time to go through all of these, but there are a number of quite significant contributions which PRIME made, either because PRIME partners were involved or because PRIME was directly cited in these policy documents. And at the same time, in parallel, we've also been involved working with the WHO and other international agencies in a number of different international global mental health initiatives. And these are reflected in these publications. And here are just some examples of policy documents or manuals in which PRIME work is cited. Then PRIME was initially funded for a 6-year period from 2011 to 2017, and DFID extended our funding for another 2 years and gave us an opportunity to reach out to other countries beyond our PRIME network. And so we've conducted workshops in 4 additional countries, Fiji, Mozambique, Sierra Leone, and we also provided some technical support to the national government of India. And this involved visiting the countries, sharing our tools, and starting processes to support other countries to take this kind of work forward. For example, in Fiji, Rahul Shidai and Inge Peterson ran a workshop, and Rahul has now developed an online training course using a lot of PRIME materials for health planners in Fiji working in the area of mental health. And then in addition, the blue shows countries where we've had requests to use PRIME tools and materials, and we've disseminated these to those countries. Also, very significantly, a lot of us from Prime were involved in the Lancet Commission on Global Mental Health and Sustainable Development. I think of the 28 commissioners, I think around 8 were involved in Prime in one way or another. And Vikram Patel led this really quite seminal publication, which takes stock 10 years on from the initial 2007 Lancet series of the field of global mental health and where we are, and critically how mental health is related to the Sustainable Development Goals. And an offshoot of this was a systematic review which we published last year on the links between the social determinants of mental health and the Sustainable Development Goals. And this provides a framework at demographic, including domains of the demographic, economic, neighborhood, environmental events, and social and cultural aspects, mapping both distal and proximal factors which have an impact on mental health across the life course. So if you're interested, please do have a look at that. And then finally, I wanted to say more about the capacity building work of Prime. We've had this wonderful group of 20 PhD students. This is Medan Salamu at her examination. She's in the audience today from Ethiopia at Addis Ababa University. And you can see here just more than half have now graduated. One has just submitted, and the remainder are still working on their PhDs. And what was really encouraging, if you look at our publication count across the 8 years, a substantial number of these publications were actually led in the yellow by Prime PhD students. And this is a breakdown of the PhD students by country. Again, you can see huge development and capacity in the southern partners, Ethiopia really leading the charge in terms of PhD students. So to conclude with some key recommendations, first of all, we think it's absolutely vital that this work is taken forward, that we need to invest more substantially in mental health integrated into primary healthcare systems. We need to stimulate demand for mental health services through community-level interventions, and it's essential that we strengthen health systems in order to deliver these packages of care. At the time that we started, and we've been reflecting over the last couple of days on where we've come, the field of implementation science was really in its infancy, and it's now grown and become a huge field of inquiry, and we think it's vital that we take forward the field of implementation science, that we think more carefully about how to scale up, and especially that we address populations which have been neglected, especially children and adolescents, and that we intervene simultaneously to address the social determinants of mental health. This is some of the links to our Prime tools, and these are also available in the reports on your seats. So please do go and have a look, and links to our Twitter handle and so on. And I wanted to just conclude by paying tribute to some of the colleagues that we've lost along the way. Alan Fisher, who really, as Vikram said, was at the beginning involved in helping us design and think through how this whole thing could be configured, and has been a mentor to many of us. And then very importantly, Dr. Sheila Ndianabanji, who also succumbed to cancer just last year and was a real champion in the Ministry of Health for mental health in Uganda for many years, and was a key partner in our work in Uganda. So I just want to acknowledge both of those. And thank you very much to DFID for their support, not only financial support, but also critically technical support and feedback along the way. And we look forward to hearing your questions and comments. Thank you so much.
Thank you, Crick. I think, as I mentioned earlier, we'll reserve questions for the panel later on. But I'm going to now invite in sequence 2 of our most important partners, the policymakers who have worked in each of the 5 countries. As you heard earlier from Crick, one of the most important aspects of Prime was the very close partnership we've had with policymakers. And in different countries, depending on where the real center of gravity of decision making is, policymakers have either sat in the central government or they've sat at the district level. And so we really have examples of both of these coming up in the next moment or two. So first I'd like to invite Mr. Chitra Sonar, who is representing the Ministry of Health in Nepal. Mr. Sonar works actually at the district level in the district of Chitwan. which is the prime district in which we worked in Nepal. Very welcome to you, Mr.
Yes, thank you.
And so I'm going to invite Mr. Sunar to speak a little bit about his experiences from a policymaker's perspective in Nepal.
Good morning.
Good morning.
Respected sir and madam. First of all, I would like to thank to Prime Program and King's University to give me this opportunity. Experience from the program for improving mental health care, Prime Chitrabahadur Sunar from Nepal. Sorry?
I think it's the other way, yeah.
Personal information, designation, public health inspector, 6th level health facility in charge. Oat station, Gitanagar Health Post, Chitwan, Nepal. Education, physical and general medicine, health assistant, 3 years course. Oat experience, 14 years in government service.
I think it will just keep pressing, or maybe, did you figure out which direction?
Yeah. Day-to-day responsibility. Every day, diagnosis and treatment of patient 10 a.m. to 2 p.m. Documentation and record keeping 2 to 5 p.m. Once a month, SMIS data reporting, Metropolitan City Office. Once a month, supervision of female community health volunteer, FCSV. Other activities, monitoring and management of immunization program, ANC and PNC clinics, leprosy program, tuberculosis program, school health program, HIV/AIDS and awareness raising activities. Involvement of Prime Program, received 9 days training on MS GAP. Mental health program, MS GAP, day 1st. Mental health program, MS GAP, day 1st. Communication skill and basic psychosocial support, day 2 to 4. Disorder specific training on MS GAP, day 5 to 8. Service delivery, history tracking, assessment of physical problem, psychosocial problem, family history of the mental health problem, etc. Assessment and diagnosed using the MS GAP flow charts and guidelines. Management of mental health problem, psycho-education, basic psychosocial support, psychotropic medicines. Personal reflection. Before the Prime, we did not have knowledge about the mental health problem. So, patients were diagnosed and treated just based on the physical symptoms. After the Prime training, we spent a lot of time to discuss possible causes of the problems, spend time for the history tracking to the patient. When we spend time with the patient and they start sharing their problems in details, we take all the patient history, and this training has helped us not only providing treatment for the mental health patient, but also other patients and our own life. This is very useful, and all the Nepalese people give the thanks to this program. They gain a lot of advantage from this program. Then, to strengthen this program, I would recommendation to this program, refresher training to the health worker, regular mechanism involving psychiatric doctor, health worker, and patient. Similarly, regular supply of the medicine. Thanks from Nepal.
Thank you, Mr. Suna. Please sit here in the front. We will have a panel discussion in a few moments. I'd like to now invite Dr. Hafsa Lukwata, who is representing the Ministry of Health in Uganda, where I understand that you have stepped into the very large shoes of Sheila Nadapangi as the charge of mental health. Yes. Welcome.
Thank you. Thank you very much. Good morning, ladies and gentlemen. It's like I've been introduced. I'm Dr. Hafsa Lukwata. I work with the Ministry of Health under the Mental Health and Control of Substance Abuse Division. I'm stepping in the big feet of my predecessor. May the Almighty rest her soul in peace. And yes, before I let you know what we have done, and looking at the reflections of what PRIME has meant for mental health services in Uganda, I would just like to give you a brief history of how far we've come in as far as mental health is concerned. I just need to tell you that we had a major reform at the Ministry of Health in 1999, where we needed to have a health policy. We developed a mental health policy, you know, and in it was then that we included mental health in the minimum health care package. And there were quite a number of things that were happening. It required to be integrated into primary health care. And at the same time, we're having decentralization, so services were put at the district. And at that time, everyone was trying to see what happens, how different things were supposed to work generally. So districts were given the mandate to recruit, to provide medicines, to provide everything to care for the people generally. And at that time, mental health was not anywhere, was not very well understood. And it was during that time that the country actually developed, got some loan and tried to build mental health services generally. How did they do this? We had to construct some major infrastructure. Most of the units we had in the country were the dungeons. As you know, most of the mental health units are dungeons. But these were made into very good facilities that would improve people's mental health. So yes, those buildings were constructed, but also some health workers were trained, very specific, and these were mental health specialists. We had both the psychiatrists and the middle group. We call them psychiatric clinical officers. So these people were trained and were supposed to be put into districts to provide services. So what then happened? What have we done so far? During that time, maybe even before PRIME came on, it was like a given. Services were supposed to be provided. But how was now the question. So when PRIME came on, it became like a pilot. It was like a pilot. How do we actually integrate mental health services into primary health care? So what did we do? They sensitized leaders at different levels about the importance of mental health services. We found this very, very interesting and very, very important because it actually led us, it improved everything. It opened the doors for mental health services to be provided. Then later we trained general health workers. Remember the program, the World Bank loan had trained very specialized people, and this could only be found in very specific health facilities. But remember, we needed to provide in primary health care everywhere. So then we had to train general health workers, people who are like nurses, midwives, and everyone, to give them a bit of information on mental health and how to assess and treat the non-complicated issues. So we also had to involve a lower level group that was the community resource persons, and we gave them basic information to be able to identify and refer. So when services began to happen, of course, then there was that we needed to mobilize the service users. There's a lot of stigma, that is one of the problems, so service users needed to be mobilized. And this, what I'm saying is PRIME was like a pilot, and it didn't take us so long. Once it happened in that district where they were operating, then it just spread out to other districts because it was something that we had to learn from. So many districts are following this process in order to inculcate mental health services into general care. The other thing that happened when we look at what PRIME has done, we've seen there's been improvement in the mix of medicines for mental health disorders at different levels of care. Initially it was just Like someone would think about the medicine and say maybe phenobarbital has to be there, and we're not clear of why and how much, and but there was this learning that we got from the project that really helped us to be clear of the kind of medicines that would go at the different levels and the kind of mix even. Then the medicines availability has also improved, yes. Just like I've said, we need, sometimes some districts didn't know how to quantify, and they were just ordering for medicines, or even sometimes the national medical stores would just lump medicines in districts without any order. But we've seen some bit of improvement in this, and we are very grateful to what PREM has done in this direction. Yeah, but also actually, and during that time, there have been quite a number of reforms, and during the time of PRIME, were able to actually include medicines that were never before on the medicines list, the national medicines list. So I find that a positive for this project. In as far as human resources are concerned, there had been a limited recruitment. Remember, when services were decentralized, many districts were learning. So some just needed maybe nurses or clinic officers and that kind of thing. And there was no special need for maybe the psychiatric clinic officers that had been trained in the previous studies. So during this time, I mean, when services started to be like formalized and, then there was a need to recruit, these specialists at the different levels. We also found that the user groups, those districts that managed to have user groups or facilities that managed to form their users into little groups, they were able to support their peers. They're continuing, we are learning, we're continuing to learn from this, but we are seeing that this is a good practice, and we are again grateful to PRIME for having brought this in light to help the country realize this. Mental health focal persons. These are mainly the psychiatric clinic officers who were trained in the other group, who took up, like administrating. They do some minimal administrative work at the district level, and they play key roles in ensuring availability of services. They keep checking the health workers themselves, the district leaders, and so on, just to ensure that services are happening and actually continuing to happen. It is not everywhere, but at least there's a bit, we are beginning to see that this is something that is actually useful. And this is a PRIME thing. This is what PRIME has really tested in the country. For the data management, I just need to say that we continue to have challenges, but generally there's been an improvement in the way data is being collected and analyzed for mental disorders. The most important thing maybe I need to mention about data management was that during that time, during the lifetime of PRIME, we were able to add we added some indicators. There are some conditions which were not following up continuously in the health management information systems. So this, we were able to add these. And of course it was, my predecessor was a very, very strong and vocal person, so she insisted that if this is what the program has found, then we need to follow it up for the whole country. And yeah, this is something that we really need to reflect upon on PRIME, what PRIME has done for us as a country in Uganda. So briefly and maybe in summary, it has been demonstrated that when health workers are trained and regularly supervised, I think I needed to put that in bold, regularly supervised, they're able to offer effective and sustained services to people with mental health disorders. Also, when services are available, realize that wherever a health worker was trained and services were available, the numbers came up, the numbers began to soar. So that is something that we need to think about as a Ministry of Health, to see that services actually are properly managed. Following the mental health gap implementation, this was a PRIME-driven program. In a district in the north of the country, there's a district that we worked with. We are trying to pilot the MH gap. And in here, we were able to come up with an intervention. Like there has to be a bylaw. Bylaws had to be put up so that we regulate alcohol use in that region. And then lastly, but very importantly, involving leaders and politicians in mental health has greatly improved service delivery in the country. So we're very grateful for the project. We're very happy for the people who have been with us, who have supported us in different ways, and we hope that we shall continue this collaboration, because the Ministry of Health cannot work on its own. It needs to be supported by different people to ensure that service delivery is streamlined in the country. So thank you very much.
Thank you very much, Dr. Lukwata. I believe now we have a short video, and that will be hopefully coming on to show us the experiences of some of the people who are beneficiaries, people with a lived experience of mental health problems.
Ngampulira tiendere irala nga bunkuba jako mu kitundu gundi jako wano naye nabire Juliet namulera omutwe obwebigwo zinalowooza ngati musuuda gwa mugongo tiendowooza nze
ये मान लो आप जैसे कि मैं जंगल में आता था, जैसे आप बैठे हैं ना अपन, तो मैं किसी काम में मेरा दिल नहीं लगता था, मतलब वो एक ही बात याद आती थी, मतलब चलो पीने। वो 7 लड़के लड़की, 4 लड़की हैं, 3 लड़के हैं, और मजदूरी करता हूँ सर, किसानी भी करता हूँ कुछ, और परेशानी पहले दारू पीता था जब, तो नुकसान काफ़ी होगा सर। मैं तो पी रहा हूँ कम से कम नहीं 15 साल की उम्र थी मेरी जब।
Tirambaayo n'emba ye yange entono nzira gw'empa yona yali awe naganga nze namulondoloosi ngamba wano muno nimpaayo endaperusi ndina emyaka 3 n'abaana 7. Era zeena ndinena mutima kunene tiyagala embeera dange kale daabaawo ditya ab'emizigo bambisaba bwe tutugemagana ezira gw'empayira kuba gwowayira akuseka buseke
naki mme Agnes ke na le bana ba 4 2 ila hlokala nna ntho e ke nahanle akiri ne ke na le mora wa ka o motho o mo bogruf ha ke fetsa mo ke hlokala ke ntato a bona yano itlile kare itla jwalo ntho ya kare yetswa ke lefuleri ke di fumane batho akere ha bana o elelwa ntho e mo wena o bane ga nako engwe ha ke dinedi ama bophelo ba ka haholo bane next a gonu o robala di ama bophelo ba ka ka hore le ke ja haholo ha ke kwatile tshwantse ke je gafetsa tshwantse ke robala ha ke fetsa mo mara ke na boroko mara ke weak tshwantse ke robala di amile haholo bophelo ba ka bane ke motho go thetse ke motho ithata ke motho sebetsa di amile bophelo ba ka haholo ne ke sa gone no o di etsa ntho tseno ka ofela ka tsona ha ke tshwantse ke tla di ja
समाजहरूले नि राम्रो ठान्थेन व्यवहार त के राम्रो हैन गाली गरिन्थ्यो गर्थ्यो मलाई नराम्रो सोच्थ्यो त्यस्तै अब जाँड रक्सी खान्छ भनेर गाली गर्थ्यो रक्सी त 3-4 वर्ष भयो लोकल जस्तो पनि खाइन्थ्यो
कान्छ छोरै सन कस्तो किसिम भन्ने रक्सी खान्छ भनेर अब कस्तो पिर लाग्ने हाम पनि खान पनि मन लाग्थेन कस्तो कस्तो लाग्ने फेरि मर्न जस्तो पनि लाग्ने अब मरम भने आफै सबै उ व्यवहार चलाउने छ म मरेर गएपछि अब के गर्छ होला घरको मान्छे
Yo masawa ya ide mai duari ya ban biya ando sera na mai dam chana amba gando biya jatambo sa
इनसे मेरी बात हुई तो इनने मुझे हॉस्पिटल बुलाया शामपुर के फलाने दिन मतलब एक दिन का गैप था बीच में दूसरे दिन में पहुंच गया शुक्रवार के रोज फिर इनने मतलब मेरा इलाज वगैरह ऐसा करवाया मतलब दवा गोली भी आगरा के दिलवाई कागज भी बनवाए सभी मुझे तो ये बात में कोई नॉलेज भी नहीं था इनने आगरा का सब काम करवा के मुझे दवा गोली दी तो मतलब उससे फिर मुझे कुछ सुकून मिला दवा गोली से सर उससे दवा गोली से जितना फायदा नहीं हो जितना इनकी बात से होया हाँ ये बात सच तो हाँ जैसे मैंने छोड़ी जैसे आप भी छोड़ दो इलाज करवा लो और अपनी समस्या उससे अच्छी होगी कोई गलत नहीं होगी जब हमारी होगी तो तुम्हारी होगी
उतैतिरको हाम्रो आफन्त चनौलीतिरको यतातिर आथ्यो अनि त्यहाँ देवीनगरमा चाहिँ रक्सी छडाउन भनेको आछारे ल पनि भोलि लैहाल भने
मेरो नाम चाहिँ विपन शाह म चाहिँ टिपी नेपालमा मनोविमर्शकर्ताको रूपमा काम गरिरहेको छु ऊ चाहिँ अल्कोहलिक डिसअर्डर को पेसेन्ट हो हैन उहाँ चाहिँ पहिलो पटक म यहाँ हाम्रो सेवामा चाहिँ मलाई चाहिँ यस्तो समस्या छ भनेर आउनु भएको थियो उहाँ चाहिँ आफ्नो बुवासँग आउनु भएको थियो उहाँलाई चाहिँ हामीले एमआई हाम्रो प्राइमको प्रोजेक्ट अन्तर्गत एमआईमा रहेर चाहिँ एमआईको रहेर चाहिँ हामीले उहाँलाई सेवा प्रदान गरेको थिएँ मैले अहिले उहाँ चाहिँ एकदमै सुधार आएर उहाँले लगभग छोडिसकेको अवस्था छ
सुरुमा त अलि अप्ठ्यारो लाग्यो मलाई पछि अनि सजिलै भयो
पहिलोको र अहिलेको धेरै फरक छ छोडेर भनेर अनि परिवर्तन आयो मेरो छोरा आज रक्सी छोडेर धेरै नै म खुसी छु एकदम रमाइलो लाग्छ अहिले त भन्छु के आफ्नो मनमा
hakense ke itla ko kliniking mo Grace mo ka ke sa gone every day buka ya ka ke bua le di sister ba mpetse letsatsi le le sister aba mpotsa hore ke tshwenya ke eng ka ke di dizzy wa bona ke di dizzy a ho mo pila hae ari o batla ke sute mo go yena ke mo after wa bona muskantle mo hona le o so tlo nthusa mo kantle o so le abayetsa he o tlo nthusa hore bothata ba ka ke eng be ke dula kore ke tlelwa ke sello ke alla ha ke utlwe monate then sister he ibi romela mo sister engwe he ibi ntlisa mo batho ba etsa bathusa ka o bua ba ntho e mokelelo isute pele ke tlhaloganye ne ke sa tlhaloganye batho bana ba ncancela ke bona ba ndutsi uri ke bone ka neti ke na le mai kgatello a maikutlo ne ke sa tlhaloganye total mari itse batho bana ba ncancela ke bona ba suthise ntho e nngwe le nngwe mona ka re ba di suthisa one by one to tsena
bonambi ngobwenali diwendi ngobuthi wena sola ngoba kuduba kumba koyaluya bit ngasobola ayuthemi monji kola akwensinziza nti ganambire yiralla era mkenda gafuuka amiri yange gafuuka kyayi wotamunwaire owulira ki
abuti entintoga mutereevu kale omuntu takamuti atakakola ki nokuwana nokwebamugana nga tekukaaliwo abuti tatiisa buti yatuuka.
Well, thank you very much for all those presentations. I wanted to say a few words about this film that you've just seen. It's only one of many different products that Prime's amazing public engagement team centered at the University of Cape Town has produced. You can also see examples of that in these brochures. But if you go to our website, you will find a huge range of policy briefs, many of which were produced linked to very specific publications that were published over the last decade, including actually some publications that were not directly linked to our work. And this was really a commitment of the public engagement group at UCT to actually disseminate, to enhance the possibility of uptake of knowledge that was being generated by the global mental health community. So this is just one, I'm sure you'd all agree, with incredibly captivating and engaging example of how one can communicate findings to a broader audience. We're running quite late, and I just wondered, Crick, I think we should have, so I'd like to invite Crick, both of our policymaker representatives, as well as Charlotte Hanlon, who became the research, you don't have to hide that, Charlotte, you can come forward, Charlotte Hanlon from the University of Addis Ababa and King's College London, who joined us as research director. And at this point, I must acknowledge also Mark Tomlinson, who from Stellenbosch University, who in fact was the research director of Prime for, I think, the first 6 years of the consortium, and who jointly led the program with Crick and I, and Charlotte, who replaced him a couple of years ago. Maybe we can turn the screen off. So Charlotte, since you have not already spoken to the audience before, perhaps I could just kickstart this panel by asking you what was, for you, the most important learnings from Prime. And I'd also then invite anyone from the audience to direct questions to anyone on the panel. Just briefly introduce yourself and to whom the question is directed if there was someone specific. Charlotte.
Okay, thank you, Vikram. So it's very impossible to find that kind of one thing. But what I was reflecting was that Prime has kind of galvanized a different way of thinking about mental health and kind of enlisted something of a commitment, particularly in the countries where we're working, but also beyond. And I think the reason it's done that is not just through good advocacy and persuasion and talking, but I think we've been able to demonstrate and show people what's possible. So I think in the communities we've been able to show that people who have been given up on and they've been able to receive care and they've been able to reclaim something of their lives. At the primary care level, we've had health facilitators, health workers who didn't think mental health was their job, who didn't think they could deliver the complexities of mental health care, who've become confident and spoken of their satisfaction. And then I think for policymakers, you know, what we're able to do now, we've done Prime, is we're able to sort of talk about really sort of nitty-gritty kind of components of how to do these things. So we can say not just, oh, it's very important to do supervision, which is of course incredibly important, but we can sort of say, look, we've shown that you can do this with a psychiatric nurse once a month, face-to-face in a group format, and we can give very specific kind of advice. So I think it's the actual doing and having that information that I think has been able to show people what's possible, even if we didn't achieve everything all in one go.
Thank you, Charlotte. I'm afraid this apparently can't be switched off. Would you want to just move your chair perhaps a little away from the glare? That helps. Yes. Okay. Oh, sorry. This way. Oh, so you're being filmed. I'm sorry. That's why you can't. You have to come back. Oh, come back this way.
We can't evade
the spotlight.
You can
come and sit here. You can
come and sit here.
Okay. Let me sit. All right. So questions from anyone from the audience for this wonderful panel. Don't be shy. Okay, well, let me kickstart. I think the point you made earlier, which perhaps might have slipped through because there was so much interesting information, is the point about training. Because I can remember countless grants, countless projects, which simply say, we train 10,000 of these and 5,000 of those and 6,000 of those. And I thought what you said earlier was an incredibly important statement, which is that training in and of itself is ineffective. And of course, there's a rich literature on this. And I wonder whether you want to elaborate, Crick, and also the others here, because you'll have all alluded to this. How can we actually ensure that frontline workers, primary care practitioners, can sustainably implement these interventions with adequate quality?
Okay, great. Thanks, Vikram. So I think one of the things that really stood out for us from our work is the importance of setting up systems, really institutionalizing systems of supervision and support for primary care workers. Because essentially we're asking primary care workers who are already burdened by heavy caseloads to take on this additional, often quite emotionally taxing work. And so they really do need support to be able to manage that process, to manage the emotional material they're dealing with, but also to keep up their clinical skills to deliver interventions with fidelity. So that's the first thing. I think the second is that we need to engage and involve primary care workers at the facility level in processes of continuous quality improvement. And I know Inga Peterson is going to be speaking about this in more detail for the South African presentation after the coffee break. And this really involves an iterative process of the team and the facility working together to identify, based on the data that are available, what a particular problem is, and then to brainstorm solutions to that problem and to test those, and then to engage in a further cycle of looking at, well, what is the effect of that? For example, if we improve our ability to screen or to assess people coming through the door who are on antiretrovirals, what is the effect of their uptake of counseling for depression, say? And then to track those over time using routine health management information systems. And it's those kinds of health system strengthening interventions which really are going to be critical if we are going to take these to scale, but with good quality and with fidelity.
Thanks, Greg. Would anyone else like to comment on this?
Yes.
Please.
Okay. Yeah, thank you very much. I think I just needed to agree with you. Like, yes, training alone may not necessarily be the in thing, because in our situation, we realize that there has to be an environment in which this trained health worker should be supported to actually provide the service. We had a situation where we even had the psychiatric nurses being employed within the system, but working in other different areas. For instance, someone is employed as a nurse, a nurse who works in a pediatric ward, and they don't have to do anything there for them. They just look at the patients and have it there. But there's a need to have it is required that the management at the facility level ensures that these people can actually work as mental health professionals. They can really, work there. Otherwise, if you just take them on, even if you train them and deploy them in other places, they may not necessarily work as required. So it is necessary that the system within where they're working, you know, is supportive of them to actually provide the service. It was actually an issue with us because we needed to integrate, meaning that we don't have to have specialized units and so on to treat people with mental illnesses. But at the end of the day, again, we realized that maybe it is something that can actually help us. If we had like a clinic, a mental health clinic, and people are seen on a particular day, at one point we thought that that was a good thing, and it would help us, and it would even help the people themselves, the patients that we are treating. So, and again, we would then have to draw whoever is deployed in other areas to be able to come on that particular day to provide that particular service on that day, you know. So, but again, that goes against the integration, as it were. But we are trying to work it out and see that since other, I think it's something that is being worked on for chronic illnesses, which mental health is, that once someone has a chronic illness, then they can still have a day, as it were. So training is very important.
Victoria.
One of the great innovations in your program is to have focused on substance use as well as other disorders. I know that wasn't initially included. From what I know of Kenya, and what I believe to be true of other Western countries, substance use treatment is predominantly privately provided. And so I'm curious how the government has responded to the proposal to integrate that as a public service, and whether you think that's something that will outlast your intervention.
So the question is really about the integration of alcohol use problems within a publicly provided primary healthcare system. Would any of you like to address that?
Yeah, I can respond. Alcohol problems were part of the original mental health care plan, so it is something we've set out to do. We were thinking about mental, neurological, and substance use disorders, so alcohol was a high public health burden. And there's good evidence for behavioral activation, and especially for brief motivational interviewing for alcohol use disorders. I have to say it's been one of the more challenging things in the overall program, both in terms of detection and also in terms of delivering intervention. So, for example, in Nepal, where we were able to nest a randomized control trial in the program and assess the effect of introducing community counselors, we saw a significant improvement for depression, but not for alcohol use disorders. So I think this is an area that really requires ongoing further work. I would say this is an area we need to do further work in. I'd be interested to hear the comments from the country teams on this, and we'll probably have more time to get into that after the coffee break.
So I will say one thing about alcohol. You're absolutely right, Victoria. This is one of the first programs that explicitly has dealt with alcohol as a public health issue. In most countries, certainly India and Nepal, which I know better, alcohol is still seen as a moral problem, not as a health problem. So, for example, in India right now, it's a major public issue to the extent where it has become a dominant theme in the forthcoming federal elections, with one party over the other vying for prohibition as a stated policy. And that gives you a sense of how important alcoholism has become in social policy in India. But ironically, there's absolutely no conversation of alcohol as a health concern. It's entirely seen as a moral problem. And so I think what we've learned from PRIME has been incredibly important to inform how one can actually offer a public health approach to drinking problems. And it's also interesting that very few development agencies, and DFID is a real outlier here, actually think of alcohol as a health issue. It's never funded by anyone. It's seen as something to do with, entirely to do with the production of alcohol, excise tax, and so on. But the actual issue of the person with a drinking problem is almost completely neglected by virtually all funders. Yeah, Charlotte.
Well, just to sort of build on this, I have two hats. So I live in Ethiopia and I'm part of the Ethiopia team as well. And the Community Advisory Board, our stakeholder group in the district, very much emphasised the importance of alcohol in the district. But it was because of this issue of it being seen as not really a medical problem. We were kind of operating in the wrong space. But beyond that, when we started off, we mapped out all the alcohol outlets. And there were a lot of sort of very poor women whose livelihoods came from producing cheap alcohol. So, it does really require a very joined up sort of development approach to tackle that. Otherwise, you're taking livelihoods away from the poorest women in the society. So I think it sort of became a bit beyond the approach that we were able to take. But but it was definitely seen as very high priority for the district.
The gentleman, yeah.
Hi, I'm Maternal with Economics International. Thank you for the panel's presentations. I was wondering if in any of the implementation sites or research sites, with this idea of scaling in mind, if you explore the use of any digital technologies with respect to training, job aids, counseling guides, or even remote supportive supervision as a potential solution for scaling, especially in light of the finding that ongoing training and supportive supervision is essential for the continued success of these types of interventions?
I think the answer might be...
I can respond.
Yeah,
I mean, basically the short answer is no when we started out. I think the technologies also weren't developed as much as they are now. It's certainly a burgeoning area, and if we were to do it now, definitely we would introduce, you know, apps for example, for primary care workers to use in detection, for referral procedures, for supervision. There's a huge potential for that area. We did use, in the course of gathering the research and doing the research, we did use tablets and cell phones to gather those data, but we didn't integrate that into the primary care systems.
So we've got a forest of hands suddenly, and so we're going to have to maybe just take a bunch of questions and then give the chance for the panel to respond. The lady behind the man. Okay, so Charlotte, perhaps you can take that question after we go through the round of questions. Then there was a lady here. Thank you. It's the gentleman at the back, right at the back.
Thank you very much. And my question is a follow-up question related to some of the scale-up issues, because I think it's very impressive result for Prime as a project. But I think what will happen if this program scale up at the national level, because in a country where there is very limited public investment, also very scarce middle and scarce professionals. And also, I think you already mentioned that private healthcare are already under strain because of a number of other initiatives and case management and a number of others. So, how this could end up in a national project. So this is a kind of like a proposal as a mental researcher, to do this in a national level.
Thank you. We'll ask you, and maybe you can also try and respond if you want to. Yeah. And I think there was one, the gentleman and then the lady, and that will stop. Yeah.
Thank you very much. My name is Jeremy from DFID. Can I first congratulate you on the enormous achievement of Prime, both in terms of research, but also in terms of the local impact that you have, obviously at country level, and as your powerful presentations in the film have shown. But can I ask you, I think one of the most important messages that you gave from Uganda is that demand source, that basically based on the experiences in the local community, that all people sought the services, which I think is one of the most important, perhaps, local
So what I suggest, thank you, that's a really important question, because the next session after tea is actually each of the sites presenting, the PIs, and perhaps we could definitely park that question for discussion after that. So I will stop there and maybe just ask each of the panelists to respond to whichever of the questions you feel comfortable doing. So Charlotte.
Okay. It was a bit of a surprise that when we trained people to detect depression, that almost immediately afterwards there was no improvement. So why? We don't really know the answer. It's not because they didn't know what depression looked like, and it wasn't because they didn't think depression was present in the community. Maybe just to show what we're doing now going forward may sort of show you where we think the money lies. So we're working on the way that primary care workers interact in consultation and helping them to sort of change their communication style, because the existing style is not very conducive to people disclosing emotional content, and it's not just about asking screening questions, you've got to make a connection. So we think that could be part of it. It could be about, you know, cultural manifestations of depression, and Dr. Ababao, the PI from Ethiopia, is taking that forward, really going back to basics and sort of trying to understand what that might be. And it's also perhaps a little bit about, you know, the context of depression and the huge contribution of social adversity factors. And primary care workers rightly saying, we don't want to medicalise all of this. And we, at the moment, at that point in time, we had medication. We are now broadening and developing brief psychosocial interventions. And we wonder, really, whether that will actually also increase people's willingness to detect, because they feel they have a more appropriate response. So I think that's what we're looking at. I can also comment on sustainability after CRIC, maybe.
No, just
you go ahead.
Well, in terms of sort of resources, perhaps in Ethiopia and the other places, I think that the countries were chosen on the basis that there was a plan to start scaling up services. But I mean, an illustration will be in Ethiopia. Sort of 3 weeks ago, we're sort of talking with the ministry about not just that we need an expansion, or there needs to be additional workload done at primary care, but also specialist services need an expansion to support that. Through the Emerald project, a linked project, we're able to do sort of resource planning through a One Health tool to sort of show in an integrated system way what that would mean in terms of additional human resources and additional finances. And it isn't for free. I mean, I think, you know, there is, if it needs to be embedded and it's not a hit and run training experience, then there does need to be, it doesn't happen in a vacuum and with no minutes. But there is uptake, and I think that, you know, it has stuck. Once we got the drug, we had a drug revolving fund. Once demand was generated, once that started getting things moving and they were selling the medication, then it became sustainable in that district. So, I mean, it's not to say that that's not a difficult challenge.
Mr. Sunal, would you like to respond to any of the questions?
Before the fry, there is a policymaker, our Nepal government, that is know about the mental health, and there is no budget in yearly budget, there is no budget, and there is no medicines. After this FRAN project, government that is the dedicated the budget in the mental health. Now government this medicine about the mental health, there is the medicine incorporated in the essential medicine list. This is the very this is the very advantage to the Nepal government, and at least it is not all the sufficient. Nepal government that is not understand why it is necessary, why mental health is necessary. They also not fully understand about the mental health. So they should be sensitized, and they should be that is the person this we have to say them what is the advantage of the prime project. That's why this program is very useful to public and government, and also that is the allocated the budget in the mental health also. And now one government that is the supply to the one mental ill patient 18,000 rupees made for the medicine in Nepal. It is passed by the member of parliament. This is the achievement by the Prime project.
Thank you. That's really very powerful.
Great, thanks. So just to quickly address the question that came from the back about scaling up. One of the findings that I didn't have time to present today is some work that's being led by Dan Chisholm, who worked with us as a health economist in the Prime team. And he managed to show through analysis of the service costs associated with the participants in the cohort studies that as a result of receiving care in the primary care centres, reductions or improvements in functioning were associated with reduced service utilization. So the economic argument is not only that providing mental health care improves economic productivity, but also can have an effect on health service utilization, which ultimately would be cost saving to the Ministry of Health. And I think those are the kinds of arguments we need to present. There is definitely a new investment that's required, but we believe over time that that investment would be recouped. In relation to alcohol, hindsight is a wonderful thing, but I think we would probably do much more in the community setting, partly because clinics are mainly attended by women in most of our settings, and most people who abuse alcohol are men, so it's highly gendered, and we would want to do much more to do community outreach to the places where men hang out, and places where men spend their time, rather than in clinics. So I think that's where we would probably go in future if we were to do this again.
Yes, okay. Just want to respond to the scale-up of services, given the challenges and the shortages in the healthcare workers in this area. One thing, I just needed to relate my answer to what she was saying, that Prime came on when, I think they must have given priority to those countries that were actually yearning to scale up. And truly so, Uganda was yearning to scale up. We're looking for what works and how it could work. So when Prime came on, it was, and when MHCP, actually it was Prime and MHCP, it somehow sorted out what we actually wanted to do. It gave us like a clear way of doing things. Actually, one of the comments from a training for the nurses, we'd had to train nurses, training schools. They were very happy that we had given them like a curriculum, a guide on how to train their health workers. And initially they were training mental health, but it wasn't so clear. They didn't know exactly how to get the things right. So when we gave them the interventional guide, it was just so clear for them. They knew what to train, how to train them, and how to interview them. And that was a two-way. For us, it was a plus, because then we would have nurses that had been actually trained in mental health, in MHCP, before they actually even come into the system. So while the ministry was trying to ensure that whoever was in service is actually receiving mental health, the MHCP interventional guide, we were also now glad that the newcomers, the new nurses who are coming on, and the health workers who are coming on, were already clear of what they should be able to treat as far as mental health was concerned. So that answers both the sustainability of services. We hope that this will sustain our services, that now a critical mass of health workers will be able to treat. But also, it is sustaining the service. Everyone now, they know what to do. We'll be able to know what to do, and for us, I think that's happy. When we go for supervision, we shall just be emphasizing on a few of these things. For the sustainability of meds and ensuring that meds will be available all the time, I think this is fine. For as long as a medicine gets onto the national medicines list, then it's a must that it has to be provided. And it's just a matter of how much you need. It just remains with the districts to know how much they will need and to plan for their people. Otherwise, I think that's a given. Once the medicine is on the list, it's a given that it has to be provided all the time. I just need to say something about the alcohol. Yes, alcohol is still an issue, as you've said. It's more of a social issue than medical. People don't imagine it's there. But in some communities, like the Kitgum, one of our districts, which was actually badly affected by alcohol, it became a medical issue. And it was taken on in a multi-sectoral way. Like the leaders thought they had something to do just as well as the social workers and the health workers as well. So it was us who brought it in, who pointed it out that it was a problem, and then they all started working together to ensure that they help their communities against alcohol. So I think there's something that we still have to do as health workers, as a Ministry of Health, in ensuring that alcohol problems are managed.
Thank you very much. Please join me in recognizing the wonderful start that we've had to this dissemination meeting. We started half an hour late because of technical problems. We're really going to try and pull back on the lost time. So can I request you all to maybe cut short the tea break to 15 minutes? Is it possible to bring tea back in here? If it is, then also that's a possibility. We can get, but we can bring it back into the hall. So 15 minutes and we'll start exactly, Yeah, it's through to the door at the back. Thank you, that was great.
All right, welcome back, everybody. Welcome back. Can you hear me? Okay, I think we want to get going. We're already running quite late because of the late start. So if we can just get going, please. Grab a seat. Mark, are you going second?
I'm second.
Yes,
so
okay.
India then.
Okay, well, welcome back. Hope you had a good break. So I wanted to take this opportunity to wish everybody happy International Women's Day. It's no coincidence that a lot of the work of Prime is focused on maternal mental health, so it's really wonderful on this occasion to be sharing all these results with you. So now we get into the nitty-gritty of really hearing from each of the country principal investigators, the findings and the experience from each country. And we've chosen in most instances to focus in on a particular aspect of one of the countries' work, of each of the countries' work, rather than trying to summarize everything that happened. So we've had the high-level overview, and you'll hear from each of the countries on specific aspects. And we're going to start, first of all, with Dr. Rahul Shidai, who's the principal investigator from the India site. So, Rahul, welcome to the floor. I'm aware that we're running a little bit short of time, so we're going to try and encourage the speakers to curtail if possible. Thank you.
Happy Women's Day and a very warm good morning. Thank you so much, and it's a privilege to be an opening batsman for this post-tea session. I'm wearing black and white, but my talk contains multiple shades of grey as I take you through the complex journey of Prime in India, implementation to scale up, and I'm going to speak about an approach to integrate mental health in primary care. Can I have my slides, please? No, this is not the one.
That's going backwards.
No. Okay. So in next 10 minutes or so, I'm going to kind of address three key questions. What was the context of our work? How did we implement Prime in India? And what did we achieve? So let's start with the context. Prime in India was implemented in the district of Sihor, which is part of the central province of Madhya Pradesh. We implemented Prime in close collaboration with the Department of Health Services, Government of Madhya Pradesh, and they were the partners right from the proposal writing phase. The context was very challenging. When we started our work in 2011, there was very low priority accorded to mental health. There was lack of sustainable mental health financing. Whatever funds were provided by the federal government were underutilized and money was returned back to the government. There was severe shortage of skilled mental health professionals, and though the district in which we were working was part of the district mental health program, there was only one psychiatrist and one psychologist who were providing services at the district hospital, leaving a vast stretch of the rural hinterland having no access to any care. Psychotropic drugs were not available, though they were on the essential medicine list, but on ground they were not available. Mental health information systems were underdeveloped, and there was overall low mental health literacy and stigma. So in this challenging context, we spent first 2 years developing the mental health care plan, and in the interest of time, I'll not go through this because Crick has already alluded to this in the general presentation. Essentially, it consisted of the core service delivery packages, which looked at the detection, treatment, and providing the follow-up care for 3 priority disorders: depression, AUD, and psychosis. But in order to kind of make these packages work, there were enabling packages about which I'm going to just talk about in a minute. So the key question is, how did we implement the program, and what were the key learnings from this implementation phase, because we feel that this is what can guide the future work. At the very outset, we were very clear that we need to work with the local health systems to create an enabling environment which could help us to provide the services. And we were guided by the systems thinking document by the WHO, and when we started our work, some of the things worked as facilitators or were very helpful in our work, and some of the things were barriers. So I'm going to talk about the facilitators first. A memorandum of understanding between the Department of Health Services and the PRIME team was a very good initial point. It took still 2 years to get that, but once it was done, then there was kind of a political, kind of a buy-in at the level of the state, and we were considered to be a legitimate entity, which helped us to also to get the directives from the government. This is what we faced during the work as well. Sometimes it works, sometimes it doesn't. So the directives from the government helped us to actually establish the information systems. We were able to kind of post 2 non-specialist health workers in the facilities, and they also provided us with some space in the healthcare facilities. We call them Mankaksh, which is a mental health a room for providing mental health services, and this was kind of a very pivotal point around which things were then kind of built up. One of the major issues in the beginning was that the state mental health authority was very critical about our work, and in settings like India, the foreign funds are looked with quite suspicion, so they kind of sent a show cause notice saying that why the state is working with this agency. We somehow had a lot of engagement with the state mental health authority. We constituted the India advisory group, and with series of meetings, we finally got the chairperson as an advisor and on our board. And some of these things were very, very crucial in terms of establishing the ground on which we could lay the future work. What we were not really able to kind of address effectively was at the level of the local facilities, the sub-district hospitals where we are working. The overall culture of providing care is quite different as what you see in some other parts of the world. Private practice is allowed by primary care physicians in the public sector. So there was very limited availability of these physicians in our program. And this was something which turned out to be quite a major barrier. Their overall readiness to change and readiness to implement the program was also a barrier which we did kind of address, but not to an extent that would have been helpful in long run. The communication between the members of our team, the primary care physicians, and the specialist was a major challenge. And though we were able to improve it, again, we found ourselves lacking on this particular bit as well. After establishing this overall background for creating the work, we actually started delivering the program, and this was guided by the process maps, which helped us clearly lay down what the key clinical services are going to be, which comprise of the pharmacological as well as the psychosocial interventions. The process maps, as I said, were a good guidance for our work, and this really helped to be kind of a key document. In India, particularly, we were able to kind of get 2 non-specialist health workers supported through PRIME work in some of these facilities, and they proved to be a major facilitator, in absence of which I don't think we would have been able to kind of demonstrate anything which we could later. In the care processes, some of the barriers which we faced was that the detection of the alcohol use disorders and depression was quite low, despite of a dedicated human resource. There were several reasons for that, but one of the main reasons was time constraints during a busy OPD time, and we were able to kind of screen roughly around 10 to 12% of patients attending outpatient clinics. Overall acceptability of psychological interventions as treatments is still a kind of a major problem. People still do not, I mean, treatment is equivalent to a pill. So to kind of establish that is still a kind of a barrier. There were errors in prescriptions by the primary care physicians who were trained in the MH gap, and we had to, over a period of time, work through this particular problem. This was at the facility level. At the community level, okay, and there was a very low follow-up rates for patients who were enrolled on the psychological treatments. It is essential to kind of at least have 6 to 8 sessions, but for most of the patients, we were able to manage only providing 2 to 3 sessions. So this was again a major problem which we face as part of the delivery processes. At the community level, there were severe time constraints for the non-specialist health workers or the case managers to actually go and conduct some of the community-based activities. And we were also not very successful in kind of getting the buy-in from the local community health workers who are incentivized by the government of Madhya Pradesh. We did engage with them, but not to an extent which could have been very helpful. One of the key learnings from our work was that, and as the representative from Uganda very rightly said, that governments need technical support, and we realized that providing implementation support or providing facilitation through our program coordinator who worked as an implementation leader and another clinical psychologist who provided clinical supervision were very important facilitators and to address some of the barriers which I mentioned earlier. In absence of this, the performance would have been far more dismal, and this particular aspect of implementation support is guided by some of the implementation science frameworks, and we definitely wish to kind of work on this further. We use the Plan, Do, Study, Act approach to address implementation barriers, about which Inga is going to kind of talk about in detail later. In nutshell, what we were able to achieve, what were our findings? So as part of the impact evaluation we did, at the community level or the population level, there was no impact on contact coverage. There was impact on facility detection, but it was minimal. And there were improvement in symptoms, symptom severity for depression and alcohol use disorders. But based on the kind of dosage of service, treatment they have received, it is difficult to kind of attribute to our interventions. The learnings from this implementation were that our program in India was focused on facilities because that's where governments, at least in India, focus on. But we definitely need more community-based interventions, more time to be spent in the communities, and it has to be bottom-up and not just top-down. I'm not going to say this again, but training is not sufficient. It needs to be supplemented by implementation support and quality improvement strategies to address barriers in the process of implementation, and new community-based resources for psychological therapies and home-based therapies is pretty essential. In absence of that, it is very difficult to expect significant changes. Finally, I would just like to kind of say a word about our engagement with the government, and as we were working with the government, what it led to was, again, this is reflective of whatever the efforts we did. The government officials were quite keen to know about the kind of service model which we had developed in one district, and based on that, they decided to kind of work with us and decided to kind of scale this up across the state. Just to give you an idea, Madhya Pradesh is as big as United Kingdom with a population of 75 million, which is slightly more than United Kingdom. And in this particular setting, they actually decided to take the model, and we worked in a sub-district hospital. They decided to do it at the district hospital. Across all 51 districts, they have established now a Mankaksh, which is a room for providing mental health services. There are 2 nurses and 1 medical officer in each of the districts who are trained to provide services. In the National Health Mission, which provides the funding, there is a dedicated column for mental health now, like 7 years. If you recollect the context which I talked about, 7 years, 8 years down the line, we now have a dedicated budget, a senior official at the ministry who kind of looks after it, and there is regular reporting of performance. There is lot more needs to be achieved. Some of these mankaks are not functional. Quality is a big issue, but I think this is a good start. This was awarded as a best innovation practice from the National Health Mission. What I feel in nutshell is that in India, at least through PRIME program, we have been able to establish a platform on which we can now build on the quality of services provided. But at least where there was nothing, we were able to achieve something. And this is all because of the efforts of not just the PRIME India team, but the consortium, the funders, whom I would like to thank. And that's my last slide, which I'm not able to show. But anyway, thank you so much for patient listening and bearing with my skills with this particular thing. Thank you so much.
Great, thanks very much indeed, Rahul. I wonder if we could get some technical support with how to do this. None of us have cracked it so far. Does anybody know where should we actually be pointing it?
This laptop is
back there.
Yeah,
so to the back of the room. Okay, great. Thank you so much. All right, so I'd now like to invite the next team leader, Mark Jordans from Nepal, to speak to us about Nepal.
Thank you. So this is going to be the biggest challenge. Yeah, great. So thank you everybody for coming, for listening. There's quite a few presentations. We're certainly excited to present it. It's 8 years of work that we're cramming into a morning, so thank you very much for coming. Also it's a privilege for me to stand here on behalf of the Nepal team. There's a couple of us in the room for TPO Nepal, working together with the Ministry of Health. So it's a pleasure to talk to you today. Whoa. That's not what I want to say. That's certainly the last thing I wanted to say. So in terms of just very briefly in the background, as in all the sites where PRIME was implemented, there's a scarcity of services available. And especially in terms of mental health professionals, but especially clinical psychologists, which I'm lifting out here because of the topic of my talk. For example, we have 0.06 psychologists per 100,000 people. So there's really a lack of human resources. So I'm going to go over this, and I'm going to zoom in. So rather than presenting the overall mental health care plan and our impact, I'm going to zoom in especially on the community components of our mental health care plan. So from the start in Nepal, we felt it was very important to not just focus on training health workers, but also to directly have elements of the mental health care plan targeting community components. So we did follow the same structure as Crick presented this morning, so focusing on the health organization, focusing on the health facility level. That is very much the implementation of the MHCP guidance, and Sunaji was presenting that this morning. And then focusing on the community specifically. And I'll zoom into those two components. One is about how do we detect people in the community to actually seek care. And the second one is around providing counseling services through community counselors. Okay. Yeah. So the first one is about the detection. So very early on, we realized that even if we train health workers to provide MHCP services in the facilities, it doesn't necessarily mean that people that require services will make their way to the facilities. So we thought in addition to supply side factors, we need to also tackle demand side factors. And Crick mentioned this early this morning already about our efforts to address this. So not just to look at, okay, there's a lack of availability of services, but also how do we get people to the services if the services are in place. So the way we did that is actually by developing a strategy using a very simple tool. And I'll walk you through that very quickly, and then the evaluation of the tool. But the assumption was, can we train people in the communities? And this could be community health volunteers. It could also be traditional healers or mother group leaders, but people that really are intimately connected within the community to identify people in their own setting that might need mental health services. So to really tap into that knowledge among community members. And to really promote help seeking. So the way we did that was with a one-sheet paper for four priority disorders that we were targeting in PRIME. So alcohol use disorder, depression, psychosis, and epilepsy. And really building a tool around a very short vignette, a very short description of a prototypical person with one of those disorders, alongside a number of pictures. So that was really the top part of the page. And that was then followed by 3 very simple questions. So we would train, for example, community health volunteers for a day or 2 to use this, and then to go back to their communities and ask the first question, do you know anybody in your day-to-day interactions that matches this prototype, this vignette? And if yes, if you think there's somebody that matches that, to then basically ask 2 additional questions of whether this person has some level of impairment in their functioning and or requires or needs services for these problems in that vignette. And if there was a yes to these questions, to then really encourage this person to seek services from the nearby health facility where we had trained health providers doing the MHCP services. So it was really just to encourage and promote the help seeking through the use of this tool. We went on to evaluate that. Yeah, sorry, so here's the basic steps that we then followed. So first, recognition, matching, assessment of needs, and then to promote the help seeking. So the first study is, our community members, and really this could be anybody that is well connected in the community, after a 2-day training, can they pick up the right cases? Because if not, this strategy is flawed from the start. And we actually found out among nearly 200 cases that they detected that they were right in 65% of the cases. And that was compared to a psychiatric clinical interview, so really the golden standard, to see, hey, how well do they pick up? So this is using this one-pager after a 2-day training. So we thought that was a hopeful and quite promising result to take it to the next step. And the next step is really not just, they don't just need to pick up the right cases or people, but then to promote them to seek services or care from the nearby health facility. That's a real indicator. So we then followed a group, another group of 500 people that were detected using this tool to see how many of those actually made it to the health facility as a result of being detected by this community informant. And we found that 67% of the people that were detected actually made it to the service, to the health facility. So again, for us, that was an important and quite a promising result, because these were people that otherwise might not have sought care. So we then took it to the next level and actually say, can we evaluate this strategy at the population level? So we basically had the full district of Chitwan where PRIME was implemented, and we ran a randomized controlled trial, basically dividing half of the district randomly to using this strategy versus the other half that didn't use this strategy. They still had community health workers, of course, but not being trained in this strategy. And then to evaluate between these two groups whether we see a difference in service utilization, for mental health care. And we actually saw that there's a 50%, almost 50% increase in help seeking and service use engagement around mental health care in the area where we did use this tool versus where we didn't. So again, we feel that as is an important strategy maybe to increase demand. Then shortly, the second component. As I said in the beginning, we had two community components that we started off with in Prime. And the second one is around community counselors providing psychological treatments. Very early on, we realized that while training health workers is a crucial element in the mental health care plan, health workers will never have enough time to provide psychological treatments. They will have a couple of minutes, maybe 5 if you're lucky, with clients, and that is the reality. So that is never enough to provide psychological treatments. So we decided to have community counselors trained to provide psychological treatments for depression and alcohol use disorders, using these two treatments that were developed and already evaluated. So they were evidence-based treatments in India by Vikram Patel and his team. So that's the Healthy Activity Program for depression and counseling for alcohol use, alcohol problems. So both of these were implemented by the same community counselors across the district. And again, we wanted to evaluate whether adding a component like that was effective, and is it worth it? Is it worth the investment of having extra counselors trained in these psychological treatments? So what we did, embedded in the cohort study that were mentioned this morning, we again randomly allocated half of the group of depression patients and alcohol use disorder patients to receiving the standard treatment that is now provided using MHCP guidance in the health facility, to the other arm, the other half that actually got the same services plus the psychological counseling through these community counselors. So we're really looking at the added value of this psychological treatment. And then, great. And then the results. So what we saw, and this is the slides are for depression. And just to help you read this, the gray line is basically the standard of care, so that is the health workers provided care, plus the community counseling. The yellow line is just what is provided by the health workers. And the graph on the left is showing changes in symptom severity, so depression symptom reduction. And the graph on the right is showing a reduction in impairment and functioning. And what you see is that both groups significantly improve over time on both these indicators, as we hope, because they're both receiving treatment, but that the group that actually got psychological treatment in addition to the health worker provided care improved actually much better and significantly better, both in symptom severity, a reduction in symptom severity, and functioning impairment reduction. And these were quite large differences looking at statistically. And it is important to mention maybe that midline, so the middle point was right after termination of treatment, but the end line was 12 months later. So we really see quite a sustained effect 12 months down the line. So very hopeful and I think a powerful argument to add psychological treatments to depression care in primary health facility or community settings. For the alcohol use disorder, and Crick already mentioned it, we did not have the same results. There was definitely a similar trend, but it didn't reach statistical significance. So we do not have the same level of evidence for the alcohol use disorder group. So maybe to conclude, I wish. Yeah. But I mean, conclude, I can be very short, is really an argument for adding, when we're thinking about integrating mental health into primary health care, to think about the integration of community elements as part of that package. And the two examples that we've given here are about case detection and community counseling. It could also be other factors, and there's definitely a need for other community elements as well. So let me stop there, but thank you very much.
Great, thanks very much, Mark. All right, we're going to try and work on improving the technology here, either by getting some assistance at the back or reducing the distance potentially. So Erica's going to do it. Great, thank you. All right, so next is Uganda. So I'd like to invite Dr. Juliet Nafut to speak. Thank you.
Good afternoon, everyone. My name is Juliet. Happy Women's Day. Because yes. I am a psychiatrist, a consultant psychiatrist in Uganda, and I also work for Prime as co-investigator with Fred Chigozi, who is seated right at the back, who is the principal investigator for Prime Uganda. And I've been working on the mental health piece of Prime Uganda. So it is women that is the reason that I'm here. We've been working in Kamuli, an eastern district in Uganda, which is very, very low resourced, where services are hardly there, mental health services are hardly there. I prefer to do the slides though, Erica. Okay. And the burden there, we think, is huge in Uganda of perinatal mental disorders. In Uganda, this has been found to be between 6 and 16% in studies that are very old, as you can see, because not much work is being done in Uganda. But despite that, not a lot of attention has been paid to mental disorders in women. And yet we know that perinatal mental illness affects outcomes of pregnancy and also affects development of children and infants. There's a recognition that services can be integrated, that there are interventions that can be integrated into maternal and women's health care. That's why I wanted to show. This is the lady that you saw in the film. This is the lady who lives in Kamuli. She was very, very depressed. As you saw, she was extremely miserable. She has many children, and you can see her bundle of not so much joy at that time because she was very depressed. So we thought that we needed to actually intervene for such women. Few interventions exist in low and middle income countries regarding perinatal depression. But there is some evidence that there are interventions that can be applied to groups or to individuals, and these must be properly culturally adapted or grounded in cognitive techniques or problem-solving techniques. Erica, you're faster than the speaker. As evidenced by Rahman's study, who did a systematic review in this area and found a few studies that have been done, intervention studies. So we went into Kamuli district with the aim to design and implement an intervention for perinatal women with depression that is feasible and also acceptable. We also had the aim to evaluate this intervention to see what effect it would have on symptom severity of these women and their level of functioning. But first, we went in to explore what people thought about perinatal depression in Kamuli, and this shows a study that we have already published in BMC Health Services that sought to explore barriers, facilitators, and needs from pregnant women, postnatal women, as well as health workers and community workers in Kamuli district. What we found, Erica, was that there was quite a few barriers. I'm going to suck Erica one of these days. A few barriers. There was perception that there's significant need in the area of perinatal mental health. There were also recognition that there were significant gaps in knowledge about mental health problems, poor attitudes and stigma towards mothers. And these attitudes were among women themselves and health workers towards mothers who were depressed. There was a recognition that there's a lot of poverty and that inability to afford transport to clinics limited access of these women. There was reported poor partner support, and this was reported by the women, but also by the health workers who take care of these women, that partners actually are not helping, and these are male partners. They do control the resources, but they don't allow the women to use these resources, even to get transport to come to the clinic, or even to give them permission, even if the money is there, to come and attend the clinics. The good news is that there were some facilitating factors. There was a recognition of need to intervene to respond to this public health problem, and a willingness by the community health workers and the facility primary care workers to provide care for these mothers if they were supported to do so. There was acceptability. It was reported that group therapy, group interventions in this particular community would be acceptable because it wasn't very new. So we went ahead to develop an intervention based on the mental health care plan that everybody has been talking about here. And the Ugandan mental health care plan has been published in the British Journal of Psychiatry. Erica? With the levels of care that we've had, district level, health facility level, and community level, we had 5 packages like all the other consortium countries. And under each of these packages, we're doing things for women, raising awareness by training, improving community literacy regarding perinatal mental health. We went to radio stations, we went to community information systems and raised awareness. Identification of women in the community, treatment, and in the facility, treatment. And under treatment, actually, we ensured that even medication, antidepressants, were available in maternity units, which wasn't the case before. They were in the general primary care centers, but not in maternity units. So we ensured that was happening, and we followed up these women and worked with the district to ensure these systems work. Next. So we trained midwives in the depression module of the MHCPs guidelines and principles of group therapy and problem-solving therapy. We also supervised them as they did the work over time on a regular basis. We identified women with depression using the Patient Health Questionnaire, PHQ-9, and then we assigned these women to groups led by midwives, group problem-solving groups led by midwives. We provided group problem-solving therapy every month for 4 to 6 sessions. That was the target. And we did it once a month, every month, because that's what we found was feasible. This was in a stepped care fashion. So women who presented with depression, who were found to have depression, were offered group problem-solving therapy for a number of sessions. At the 3rd session, if women didn't show any improvement, we referred them to a specialist clinician who would then add medication, antidepressant medication, to their treatment. Mothers with severe depression scores or who had suicide, according to the PHQ-9, were referred to a specialist. We never included them into the group. We also included support for intimate partner violence because we found in our qualitative assessments that this was such an issue. So we thought this would underlie the depression. So we worked with an NGO which was based in the district, working specifically on IPV, and we referred women there for help. We evaluated our intervention. All women who scored 5 or more on the PHQ-9 were recruited into a cohort of group problem-solving therapy. And we used a cut of 5, basing on a validation we did. We haven't shown the paper, but we did a validation which we published in Global Mental Health Journal 2016, where we found that in that particular community, the best cutoff was 5. So that's what we used. And everyone who scored 5 was recruited. Consecutively, we recruited 153 second or third trimester pregnant women and evaluated outcomes after group problem-solving therapy every 3 months, midline, and endline at 6 months. We measured change in depression scores using the PHQ-9 and change in disability or functioning using the WHODAS, the WHO Disability Assessment Scale. This is what the population looked like. About a quarter of them were actually very young people, 20 and under, basically adolescents. That population has a lot of adolescent pregnancies, so we picked up quite a number of those ones. The majority, this little circle in the middle should have been at the 79. About 80% were in a relationship of some sort, you know. They were married to a partner. The majority were illiterate or nearly illiterate. They had not attended school or had not completed primary school, as you can see. Only 18% had gone beyond 7 years of school. So it was quite an illiterate population. Most of them, about 2/3, were not employed. They were stay-at-home moms. And some reported that there was food insecurity in their home, about 17%. Next. About a third, which I thought was very good, received the targeted number of sessions, at least 4 sessions. What was interesting is that some came back for a 7th session, which was more than what we had prescribed, actually. It told us that maybe this was well received. 45% received 1 to 3 sessions for various reasons. 18% did not attend any session at all. Erica? And this is the results after the intervention. What we found was that the mean PHQ scores dropped significantly in this group. So did the WHODAS over time, over the 6 months period. Erica? And this table shows that this was very significant change. Okay. We also found that there was 50%, there was symptom reduction, which we called clinical response, 50% reduction on the PHQ-9 symptoms in 69% of the patients at midline and 93% at endline. We thought that was quite impressive. Erica? We wondered what to make of this, this data, but this is preliminary data. We wondered whether the improvement was due to our intervention. It could have been natural resolution, but we're still looking at the data. Our challenge was that we didn't have a comparison group, but I think the results are still very encouraging. Erica? Did we have any challenges? Yes. Time constraints, and this is a real challenge. When you're working in a maternity setting with midwives, they're usually very busy. There's a very huge patient load. Low motivation of midwives for various systemic reasons. What I didn't put here is that there was a little bit of attrition from the people we had trained, people would take away, and that caused a little bit of a challenge. Inadequate provisions within the HMIS to record mothers with depression. There wasn't such an indicator. It demotivated midwives. They didn't want to do it if no one was going to measure it. Lack of transport, as reported by the women to get to the clinics, led to some of them not turning up as expected. And of course, there was stigma. Group therapy in Ugandan clinics is seen as HIV groups. You know, HIV care has been there for a long time, and they do a lot of work in groups. So mothers were being seen in the community as if they had HIV, and this was a deterrent for them to come. It was such a barrier. Next. What did we conclude from this? One, that there was perceived unmet need for maternal mental health care, but there was a willingness to address the need in this area. There were personal and systemic barriers that limited access to such care. We did intervene, and we found it was necessary to intervene at different levels of the district healthcare system for it to work. It is important to note that it was feasible to integrate group problem-solving therapy for maternal depression, especially delivered by midwives. And when it was delivered by trained midwives and supervised midwives, it resulted in significant improvement in maternal depression symptoms and social functioning of the patients. So this has implications for policy. And every time I look at this slide, I want to say very loudly so that Dr. Hafsa Lukwata can hear it again and again, that it is feasible to integrate maternal depression care in primary maternity care settings. We've been talking about integrating mental health care into primary care, but usually we talk about the general healthcare setting. We don't usually talk about the maternity settings, and I think we need to be thinking in that direction because it is feasible. Group problem-solving therapy holds promise for perinatal women with depression in Uganda and probably beyond that. PRIME has provided evidence and a framework to enable scale-up other districts in Uganda of care for perinatal women with depression. Next. So that we can have women smiling like this. Women who are happier, productive, and who are looking after their infants better, for better development. Next. I would like to thank DFID for making this work possible and all the actors for all the contribution. Thank you very much.
Thank you very much indeed, Juliet. I'd like to now invite Professor Abeba Fakadu, the Principal Investigator for Ethiopia.
It's now good afternoon, and thank you so much for your patience. It's definitely a privilege and an honor to speak to you and communicate our 8 years of work now. So I'm primarily focusing on psychosis, and what I want to do is demonstrate that integrated care into primary care delivered by primary care workers with limited training works for psychosis. And the reason I want to emphasize that is often we think psychosis requires specialist expertise and so on. It does require specialist expertise, but when there are no specialist experts, you want to provide the care where people are in a safe and quality way. And that's what we try to do, and that's what I will try to demonstrate in my presentation. Thank you very much. So when we started the work, most of you might know, some of you might know, that in that district and nationally in Ethiopia, only 1 person in 10 was receiving care for psychosis. And for epilepsy, it is about 1.5, there is a 1.5. 87% of people do not receive care for epilepsy. That's data from the northern part of Ethiopia. This picture is about 2.5 years after we started the PRIME implementation work. And 2 years was spent on the planning part of it, and we just started implementing, and we had the usual 6-monthly community advisory board meeting. And one of the community advisory board members, called Membara, she insisted that we have to go and visit a family somewhere. And she didn't explain what it was in any detail. So we said, I wasn't sure what to expect, and I wasn't also sure whether our program was doing much. So she took us, we walked to that house, and there was this 2-room house there, and there was a young lady with a child, and there was a frail-looking lady, probably in her mid-50s or so. And there was a young man there, and they were making coffee. And this lady was making some baskets in the corner. And then they told us the story that this lady was living on the street next to that house. And that the lady next door, when the treatment and care started in the primary care setting, had taken pity to this woman, had taken her to the primary care setting to receive treatment. There were other issues linked to that. Anyway, and then this lady started treatment. This lady took her on her own accord, no pressure at all. But when she took her to hospital, she describes quite a dramatic scene. So the lady was on the street for about 8 years, and she was putting on all the clothes people would give her, and then the dust and everything else. So how they described to her was that she looked like a small van when she's sitting. And because she was really aggressive, no one wanted really to approach her. So anyway, at that particular time, she had some additional illness, so she was more amenable, and there was a care. So this lady picked her up and took her. So we're seeing this lady 2 months after she started care. This woman was the lady who was looking after that patient. It's not the patient. So we invited this woman then to come and explain what happened. This is when this woman was explaining what had happened. And that lady, once she got better, she remembered who she was. She remembered her family. She asked for her son to be tracked. By that time, her son was a grown-up man. He has married. He has a young family and a child. So what he decided to do was rent a property in the neighborhood, get his wife with his child, and keep the wife to look after the mother. Now they have moved on. This lady now makes baskets to sell and other things with her family. This was homeless woman for 8 years. But I also don't like anecdotes so much because they kind of exaggerate the story. But this is not anecdote. This is typical story. If you look at the lady with white scarf on her head, this lady was tied up by the street against the big tree. A commander who was a member of our community advisory board saw her. Then he went to the family, explained that there was care, and then she received care. In a few days' time, she improved. And you know what the first thing she asked for? She said, "I'm now feeling better. Can you please take off the restraint?" That's what she said. And that they did. She recovered completely, went back to school. She was 4th grade when she became sick. She's now a member of the advisory board with her brother. This is when she was 8th grade, a very good student. And I could mention a number of examples, after examples, pregnant homeless women who were looked after, and so on. So in Kella and Bui, where this happens, now for the past 2 years or so, there are no homeless individuals. What happened? There was a clear impact in my mind when this actually happens and people witness and see it. So, just so you don't think it was just straightforward, I'll just quickly. So this study was, this implementation site is the Sodoso District Historical Place. This is a UNESCO site. 180,000 people currently live there. And it's the largest in terms of size, the largest in the region of 50 million people. The scale-up site is the whole of Kyrgyzstan. I'm not going to talk about that. Of course, every mental health care intervention, especially any integration work, requires complex intervention approach. I'm not going to go into the details, was already mentioned. But suffice to say, we had very close contact with the leaders. This is the head of the district health office. He's as busy as you see him here, very busy. This is the first day we got him and he was on the phone. But he's always like this. This is the community advisory board. So what they did was We had regular 6-monthly meetings. These are representatives of the people as well as the politics. They put pressure, enormous pressure on the leaders to make treatment accessible, to make medication available, and so on. These are important milestones or crucial steps for us. And we also needed to understand the context. So this distribution shows you the amount of resource available within the community. I have to confess though, we haven't tried that hard to use all the resources available, but there was a lot of resource. Everything mobilized within the community was spontaneously generated or provided by the community. But there was a huge amount of resource that we could tap. We tried in the community-based rehabilitation work we did. And it was just to emphasize training on its own, it doesn't work. We had experience with it, so we focused on skills-based, engaged, continuous training program. So what happened? What was the impact? I'll start with a short version of it. So I said initially the national care coverage was very low. It was about 10%. 1 in 10 individuals had access to care. When we started care and provided care, that increased to 81%. I haven't got epilepsy here. Epilepsy is even bigger. The second thing, what we saw was what primary care providers, when they made diagnosis, when they provided care, it was of adequate quality. So for epilepsy, for example, the match between the diagnosis of specialists and primary care workers matched 100% when we checked it at 10%. Looking at the whole population here for psychosis, 95% match. This was really very good indicator of quality of care that could be provided. Not only that, the engagement, ongoing engagement in this implementation site for psychosis was also good because the average number of people that received care was good enough. And the male to female ratio was also good enough. And just one last point to make, new cases, very good indicator whether a service is working. It's more or less what we would expect incident cases more broadly would be like 62 new cases seen. Next, please. And to actually understand the actual impact of our treatment on the individual patients, we had a cohort study of 300 individuals with psychosis. Yeah. So the higher level clinical and social impact was the overall functioning was improved, symptom severity was reduced, discrimination was reduced, and restraint went down from 1 in 4 to 1 in 10. Still not satisfactory, but good enough for now. Next, Eric. Next one, please. So, and then suicide attempt was also substantially reduced between the first time we started care and the next time. Alcohol use also was down significantly. Next, please. And this is the more technical stuff, so if you wanted to look at it. So between baseline and inline, disability improved significantly, statistically significantly. Clinical symptoms, depressive symptoms, suicide attempt, even discrimination improved significantly at the end. What you see is food insecurity as an outcome. So the family food insecurity also reduced between baseline and inline significantly. Family burden, again, in all the subdomains you see, improved significantly in the cohort. And the service satisfaction among patients was also very good. I don't have time to go into the details, but this lady is talking about her functioning improving and returning to her usual self. Next, please. And this health extension worker is talking about the community witnessing the change that had happened as a result of the PRIME intervention in the community and wanting to engage with the patients and the population. Next, please. Again, this is a very similar story from a health extension worker who is talking about a homeless person who recovered or improved substantially, started to look after himself. Almost the end. PhD, we'll link it to Prime. I'm counting one postdoc here, so 14 is the precise number. Anyway, 7 of 15 PhD students we have in the department are supported to do psychosis research. So this is something or research related to psychosis. So in terms of capacity building, has also has done substantial work. So going back, so I don't want you to lose hope, but I think what we have done, this is just one district. For treatment of psychosis and epilepsy, we have a working model. But this is only one of 770 districts. Okay, so there is a long way to do to work together on this. I just want to finish by, it's not my place, I know, but I always do this. I just want to say thank you to the UK taxpayers and DFID, of course. Yeah, and I genuinely say thank you. Thank you very much.
Great, thank you very much indeed, Abibal. Okay, I know it's been a long morning. We've got one more country presentation, and so I'd like to invite Professor Inge Peterson to speak about South Africa.
Okay, so I'm going to, just on behalf of the South African team, I'm going to move us a bit beyond the results of the implementation phase towards scale-up. And talking about how we're going about scaling up the evidence-based prime intervention in South Africa, and particularly one component, which is looking at integrating depression into chronic care. We did other things as well. On the wall, you'll see a photo essay of the psychosocial rehabilitation program that we developed, but I'm not going to focus on that. So this is just a visual then of where we came from with the implementation study, which a lot of the countries have presented results on. We then did a horizontal scale up through 2 trials, and this work was in the Northwest Province of South Africa, in the Dr. Kenneth Kawanda district initially, and then Bojanala, and that gives you a sense of the number of patients reached. And now we're involved in vertical scale-up, and we did get some multiplier funded to assist us with this in terms of a technical support partner. And we're working in KwaZulu-Natal, starting in the Amajuba district. KwaZulu-Natal is home to 11 million people. And we've also we're working in Mpumalanga in the Eslanzeni district, which is where the Kruger National Park is, if any of you know where that is. And then we did also continue to scale up in Dr. Kenneth Kawanda. So that just gives you a visual of where we've come from and where we are just geographically as well. Okay. So the focus of what when we're talking about is really this collaborative care model for the treatment of comorbid mental disorders and chronic care patients in South Africa. And this is really important in South Africa. We were asked to actually focus on this population because of the clashing HIV and non-communicable disease epidemics. In South Africa, we've got about 7 million people HIV positive and approximately 4 million on ART. So it's a huge investment. It's the biggest investment in the world in antiretroviral treatment. And we know that depression in particular interferes with treatment adherence and can compromise health outcomes, as well as compromise the huge investment in the ART program. Erica? Okay, so that's the collaborative care package that was developed and adapted for scale-up. At the center really is the primary healthcare nurse who identifies and now can start to initiate. This is a very new thing, treatment on antidepressants. And then referral pathways to a lay counselor, primary healthcare doctor, or psychologist, depending on severity, as well as then the support and supervision around that. Okay. This is what we did is we modified the package we developed in Prime for scale-up. And this really meant ensuring that, because the primary provided quite a lot of support in terms of training and supervision, so we had to transfer that to existing resources at district level. So you'll see that we developed trainer packages for the counsellors, for the doctors, for the nurses. We integrated clinical communication skills into the training of the mental health module, which adopted the MHCPs modules of the chronic care guidelines that are being used in South Africa. And that's really important. We found that to be very important to promote person-centered care. And the district package, we're developing a capacity building program for mental health coordinators in all the districts, and the red is stuff that's still in process. And we also developed a training package for primary health care coordinators in continuous quality improvement, and I'll talk more about that. And we're developing a package for the provincial managers to mentor the district mental health coordinators as well. So the lessons from Prime informing the scale-up was really that, as you've heard repeatedly, training is not sufficient, but we really need a systems approach to strengthen the health system to enable integration. And continuous quality improvement really provides a vehicle for change management, both in the software, which is your norms, traditions, roles, because it provides an empowering approach and builds will to implement changes required, as well as promoting teamwork for collaborative care, and also allows for small policy changes that we identify along the pathway when implementing continuous quality improvement in the hardware of the system. Okay, so what is continuous quality improvement for people who don't know? Basically, it uses data to identify problems, generate change ideas through systems analysis, then after looking at the data, and then engage and plan, do study, act cycles, and then see if that's actually made an improvement. Next. So how did we go about doing this? Next slide. So we developed, holding this scale-up package together, and you've seen this Crick did present it, was this operational manual that we developed with all the accompanying tools for scale-up. And the first part is planning, which involves a lot of engagement with national, provincial, district, sub-districts, and also assistance with doing situational analyses and developing district mental health care plans. And what was really important from the CQI perspective was actually leveraging, and in South Africa we're quite fortunate because of HIV, there has been the establishment of CQI committees at all levels to monitor the HIV indicators. So we leveraged these CQI teams, facility level, sub-district level, district level, and provincial level, to add the mental health indicators to what these teams were looking at. So actually looking at mental health indicators that were in the system alongside HIV indicators. And we've also been working closely with the NCD Directorate to add the other NCD indicators, so that we've got a comprehensive approach. And then in terms of prepare, next. We have been capacitating the facility managers in both CQI and including the mental health indicators into the CQI framework that they were using, and really to orientate them to the MINT program. Next. And we, what is quite helpful is to show them where they stand. So this is the Newcastle sub-district, and this is number of patients screened, which is one of the indicators in the information system, next, compared to number treated. And then they go, ooh, so there's an immediate problem, right? Okay. And so it sort of triggers their buy-in, next. In terms of the provide, then it's really a mentoring process where the CQI mentor then provides mentoring to these committees. At the facilities, they meet once every month, sub-district every 6 months, 6 weeks, and then a learning session of all the facilities in a sub-district then every 3 months. Next. So how did we go about doing it? We first identify what are we trying to accomplish next. And the aim being to assist the KZN Department of Health to achieve integration of mental health services next. How do we know we'll make that change as an improvement next? So we work together to develop process maps where we map on the mental health activities onto the process map. That's already there. Next. And then we attach indicators to these various, along the cascade of care, so awareness, morning talk, screening, assessment, intervention. Next. And then how do we know that a change will result in improvement? We engage in the plan, do, study, the ACT cycle, we identify the bottlenecks, conduct root cause analysis, generate change ideas, and then review data. Next. So just some examples. Next. So what you see on the left is the mental health screening rate by clinic in the Newcastle sub-district when we started, and you can see that their target was 90% of the headcount, which was perhaps a bit, they adopted the 90-90-90 targets. But the problem really you can see is poor quality of data, with one clinic at 140%. And when, which just shows that in fact they weren't really rigorous in this. And so the root cause was identified as a lack of a standardized screening tool leading to unreliable captured data. So anecdotally we were told, well, you just look at someone and you say you've screened them. Okay? The change idea was to develop and test the standardized screening tool, which we did, and that would be used as part of the screening in the vital signs screening room, together with blood pressure, etc. And then the policy change leading from that, after the validation of this tool, has now been adopted by the KZN Department of Health, and they've requested for us now to develop a standard operating procedure for how to use it. Next. And then just looking at the other one indicator that's in the system is now the intervention initiated, and the indicator is number initiated over number assessed. Okay, next. So here is another example. So we looked at the number this is the number initiated on treatment rate. So we noted that the DHIS data does not reflect the intervention data we were collecting in MINT at the same time period. And that was because only patients put on medication were being recorded, and they did not reflect the counselling. And then another problem is they didn't have an indicator for number assessed for the denominator. So the change idea was to develop a SOP for recording the number of patients receiving counselling without medication, and to include as an indicator a denominator for the number assessed. So the policy change is to add new data elements to the indicators of number screened, so record patients who are counselled as well as add additional indicators, which has been taken up by the KZN Department of Health. Next. And so here we can just see this was introduced, the change in the collection of the data elements in the two other sub-districts in the Amajuba district, and you can see where we started and how there was an improvement then in number treated. This is December, and we expect a decrease. Okay, next. And the same in the Emandangeni sub-district, and this is December as well. Okay. So lessons learned from this process. The CQI process is helpful to generate will to integrate mental health into primary health care, as well as empowering staff to take ownership of the process. So we have heard before that organizational readiness is really a challenge. Next. But to do this, staff need decision latitude in order to be able to generate and implement change ideas. And this really requires transformational leadership style, and we've got a challenge because we've got a very bureaucratic leadership style. Working within a CQI approach at all levels, from district right through to provincial level, helps to facilitate policy changes small policy changes to enable integrated care. And an important lesson for us was actually historically we've just been engaging with the mental health directorate, but there's a real need if we want to integrate into primary health care to be actually working a lot more or in tandem with the primary health care subdirectorate. Because our mental health coordinators don't report to the mental health directorate. Our mental health coordinators in the district, they report to the district managers who report to the district services at provincial level. So they tell them what to do. And especially if we want to have our mental health indicators become part of the primary healthcare indicators, it's these people who will decide that. Okay, so organizationally, we need to be very careful about working vertically when we're trying to integrate mental health care. Next. And lastly, what's very obvious for all of this is there's a need for technical support. So this is an advertisement to donor funders of where money should be located, but just also a concern that be careful of I'm very worried about us following the route of HIV, which tends to verticalize services. So when funders are giving funds, to think about integration. So especially in HIV and NCDs, and so it should be an integrated package, because sometimes donor funders actually cause a problem on the ground for us because they promote verticalization. Thank you.
Great, thank you very much, Inge, and thank you to all the country teams. So I'm going to just invite all the country teams to come up, and we'll have a very brief panel discussion. I know we are running quite late. We'll restrict it just to 10 minutes. So if you have any questions, it would be lovely to hear from you, and you're of course welcome to speak to the PIs over the lunch break as well. So please do come and have a seat. I'm told that you need to sit in the limelight to be seen on the streaming. So please do claim your place in the sun. Okay, good. So let's open the floor to questions. Anybody have any questions?
Julia?
Yes, please.
It's a question for Nepal, really. I mean, I guess I know during the time of Prime, there's been great recognition that antidepressant medication is less effective in mild and moderate depression. And I was interested to see that counselling made a difference between treatment as usual, which presumably would be with antidepressant medication. I wonder if you compared placebo to antidepressant medication, and whether actually antidepressant medication helped provided any addition to just the natural resolution of depression that you were seeing, and whether actually the active intervention is counselling rather than antidepressants.
Yeah. Do you want to take
please,
it? Yeah.
You can respond.
So very good point, and unfortunately we didn't have the opportunity to add that. It would add a third arm basically to the study. It was important to, the starting point was saying MHCP interventions are evidence-based interventions. So what we were, with the cohort studies, what we were trying to establish is if those evidence-based interventions, which includes pharmacological treatments, are implemented by primary healthcare workers, do we see the change that we're expecting? So that was the primary research question. We then embedded within that the trial to see what is the added value of counseling, which we demonstrated it had. Unfortunately, we were not able to have that question answered, which would require just a third arm, basically. So very good point, but we just don't have the data.
Okay, thank you. Other questions? Yes, please.
I was interested in the low acceptability to psychological treatments in India and how this compared to Nepal, and if maybe some of the community-based work in Nepal improved the acceptability of psychological treatments.
Okay, so that's for Rahul.
Yeah, so again, this is based on the data we have of the qualitative studies and our own experience in the field. The way we had structured our program was facility based, and people were actually not coming there to seek treatment for depression. They had come for other physical problems. They were screened and then they were given the option to kind of be part of the program. So that might be the reason why the overall acceptability of even the diagnosis for the depression as well as the treatment which follows might be low. And I agree with you that the community based components could have been very helpful in terms of improving the acceptability as well as the continuing care aspect of it. The only problem we faced in the beginning was with limited resources, you could either work with the facilities or communities, and government being the collaborator, we had to be guided by their preferences. So we went ahead with the kind of a model which suited that particular context. Thank you.
Thank you. Another question here? Yeah.
Yes. I was wondering if people that are experiencing poor mental health or have experienced poor mental health had been included in the development, delivery, the monitoring and evaluation of the work that's being done.
So is it for all the country teams?
Yeah, any one of the countries.
Anyone like to respond to that?
Yes. In Uganda, when we were doing the theory of change workshops, which were the basis of developing the interventions that we developed, we had some service users actually within their workshops advising on what could be appropriate and not. So yes, they were involved, at least at the development stage.
Okay. And how about further through the work? Are there any examples of that?
So in Ethiopia, I mean, generally it's not easy to get service users involved, but we currently are trying to have a program purely to develop that capacity. We have a PhD student working on that, essentially trying within the prime side to develop that service user capacity more broadly. In terms of the actual prime intervention, yes, as was said, they are involved in the theory of change workshop, in the mental health care plan aspects of it, and in the training also. We didn't do it every time, but we had also patients who were explaining their experience and what had happened as part of the training and desensitization work. We had patients involved in that. In the community advisory board, initially we didn't have any, and at the latter stages, we had 2 service users and 2 carers involved. Actually 3 carers involved in the 6-monthly community advisory board meetings. They always make crucial contributions.
Can you speak for Nepal, Mark?
Yeah, it might be nice to, and this is really in the later part of the program where we added, and this is just an example, service users as part of the training of health workers. So we actually had service users that came into the training throughout the 9 days to give recovery stories, to provide contact with the trained health worker, with people that had experience with mental health problems. So that was is now an integral component of the training of health workers, basically aiming to reduce the stigma among health workers themselves in providing healthcare. And what we're able to demonstrate is that the level of perceived social distance among the trainings where we integrated this service user component in the training was much bigger when compared to when we didn't include it. So this is now a part and parcel of that package.
Okay, that's right. I just think it's a very powerful tool to use.
Exactly. It's a great question. Thank you so much. Thank you.
So, I mean, I think that, you know, it's really underpinned what we did in the theory of change workshops across the country is co-designing. And so, I mean, I think that the whole sort of approach was to actually involve, you know, everybody, all stakeholders in those theory of change workshops, including service users. And, I mean, I think that through, you know, the CQI approach as well, it's very participatory, involving staff, not patients so much. But what we did find in South Africa to improve actually staff referring patients to the counsellors was to get some testimonies from patients who'd received counselling, and that was very effective as well, to actually, you know, because there was some hesitancy to refer to lay counsellors.
Good, okay, thank you very much. I'm afraid we are running very late, so that's probably all we have time for now, and we're going to move on quite quickly to the PhD presentations. So thank you very much to the country teams. Good. Right, and Charlotte is going to take over from me to chair this session. While she gets a microphone, I'm going to keep the conversation going, which is just to say we have, as I mentioned, some 20 PhD students who've been involved in PRIME. We now have an opportunity to showcase just 5 of the PhD students' work, and they are each giving very brief, rapid-fire, we're calling them presentations of 5 minutes each, summarizing their PhDs more or less in 5 slides. So no small task. I just wonder who's coming first.
Why don't you do it because they're not going to...
Okay, so could we have the first presenter?
You're just getting mic'd up. Sorry, we only have 5.
All right, so we're just getting mic'd up. Unfortunately, we only have 5 microphones, so we need to just do a quick transfer. If you would like to, please feel free to stand up and stretch your legs. I know it's been a long time sitting down. And we will have lunch provided just straight after the PhD students' presentations.
I was going to ask you about what happened next.
Yeah.
And I thought it might, but I thought it might be a bit different with DFID sitting here, so I didn't.
Yeah, well, the funding does come. Oh, I don't know if I'm on my mouth. The funding does come to an end now, and so basically the project ends in April. Various of us are involved in bids for other kinds of continuing work, and a lot of us are going to try and do some more work with children, with adolescents. That's really going to be the big focus of our work going forward. But there are, as I mentioned, other spin-off grants, like the Health System Strengthening Grant, which involves Ethiopia, South Africa, Zimbabwe, Sierra Leone. The India team is involved in other spin-off projects. The Nepal team is all. So the work continues in each of the countries. It's just not going to be configured in this specific way.
I may step out.
Yeah, sure.
I just wanted to say
Good
thank
to
you so
see you.
much.
Thank you so much, Chris. Thank you for coming. Are you okay?
Yeah.
Yeah.
Hi, can you hear me, everybody? Yeah, great. Right, we're going to start back again. Thank you very much. Sorry to interrupt. So as Chris said, we've now got our early career researchers, PhD students who have all been embedded within PRIME. We're going to have 5-minute back-to-back presentations, and then we'll just have probably time for 1 question each of the students. So first off is One Selehilwe from University of KwaZulu-Natal.
Good afternoon. As Charlotte has already introduced me, my name is One Selehilwe. My background is in clinical psychology, and I work in PRIME South Africa as a project coordinator based at the site. The title of my PhD study is the development, implementation, and evaluation of a task-shared intervention for comorbid depression in a real-world setting in South Africa. And the first objective of this study is to understand the exploratory models of illness that service users had for depression in view of informing the
informing the development of a culturally appropriate and locally relevant psychosocial intervention. The second objective was to evaluate or to look at the relationship between the levels of exposure to the intervention with psychosocial outcomes, specifically depression, functional disability, and internalized stigma at 3 and 12 months follow-up. The third objective is to understand how the intervention produces change and how the service users interacted with the different intervention activities. And the fourth and final objective was to explore challenges and opportunities for scale-up. I'm going to go on to the findings for the first objective. Interpersonal conflict, grief and bereavement, experienced stigma, perceived or internalized stigma, social isolation, and poverty were identified as triggers of depression. We also identified a need for a psychosocial health talk in the facilities, in the waiting rooms, and that was to help with the mental health literacy to enable the service users to be able to report their experiences to the nurses who were doing the consultation. Findings for objective 2 with the PHQ-9. You can see here there were different categories of the sessions, 0 sessions, 1 to 4 sessions, and 5 to 8 sessions. 5 to 8 is the one in purple. Overall, there was a significant reduction in depression severity at 12 months follow-up, and participants who received 5 to 8 sessions had the greatest reduction in PHQ-9 scores. With the HUDAs, once again, there was an overall improvement from baseline to endline, and participants who received 5 to 8 sessions had the greatest reduction in functional disability. Going on to the internalized stigma, once again, improvement from baseline to endline, and greatest reduction in 5 to 8, especially when compared with participants who received 1 to 4 sessions. Then objective 3 findings. The service users reported that the service was both acceptable and accessible. We found that session attendance was hindered by the women's caregiving burden, poor counselor attributes, and poor referral processes, whereas attendance was promoted by the actual intervention being available at the facility, being aware of the changes that are taking place in the service user, therefore getting encouraged to come for more and see how much more they could get, as well as their counselor qualities. Participants who received 5 to 8 sessions reported improved functionality, reduced self-stigma, and they reported to have been empowered to be able to self-manage, to be more self-reliant, and were capacitated with skills which improved their quality of life. Conclusions and recommendations. Clearly, as you have seen, the 5 to 8 sessions were found to be optimal in reduction of depression symptoms, as well as reduction of functional disability and reduction of internalized stigma. Factors promoting attendance included counselors with person-centered care qualities, referral processes that included being provided with an explanation as to what to expect when you go for this intervention by the person who's doing the referral, as well as being connected to the person who will be providing the intervention. This could be by walking the participant over to the counselor's room or getting them introduced to the counselor. And that brings me to the end of my presentation.
Fantastic. Thank you, Ane. Now we're going to move swiftly to Nagendra Lutil from Nepal.
Good afternoon, everyone. I'm Nagendra Lutil. I'm a PhD candidate at Utrecht University, Netherlands. And my supervisors are Professor Ivan Komproy and Professor Mark Jordans. This is a bit about my background. My background is social science. I did my master's in population studies, and I'm also doing my MPhil on public mental health from University of Cape Town, South Africa, and I'm waiting my results. And currently I'm working as head of research at Transcultural Psychosocial Organization in Nepal. And I'm also a project coordinator for PRIME in Nepal. And the aim of my PhD is to systematically describe the process and evaluate the integration of mental health and psychosocial support service into the primary healthcare system in Nepal. And this is the overview of my PhD. The first, I assisted the burden of mental health problem in both community and health-seeking population in the first stage. And second, I systematically analyzed the situation of mental health care in Nepal. Also, I assisted the barriers why people they do not seek services. And based on the findings of these both studies, and we developed district mental health care package involving a wide range of stakeholders, and the mental health care package included the intervention package delivered in community health facilities and health organization level. Then we evaluate the package using multiple methods and contact coverage and detection and patient level outcome. And finally, I have described the challenges and facilitating factor in the final chapter. These are my key findings. It's like in many other low and middle income countries, we found a high rate of high prevalence of mental health problem in both the community and health-seeking population. And the prevalence was 11.5% for depression and 5% for AUD in community sample, while it was almost double among the health-seeking population. And the next thing is we found a quite large treatment gap on mental health care. You can see like more than 90% people who were identified as a depression, they did not receive care in the past 12 months. And the major reported barriers were the lacking of financial means to pay for service, and also some of the barriers were related to the knowledge about the available service, and of course there are many barriers that are related to stigma and discrimination. Next. And another finding is that the Nepal mental health policy was developed in 1996, which has committed to provide basic mental health service to all by 2000. But when we started PRIME in 2011, it was never implemented. At the same time, the available facilities, mental health services were only in few health facilities located in the big cities, and out of 75 districts, only 7 districts had mental health services. And of course, traditional healers and religious leaders were the primary service provider in the community. And I will not be discussing much about this slide because this is a patient level outcome that has been discussed in previous slides. We found a quite significant reduction in PHQ-9 score, that is symptom severity, and in depression cohort at the same time in functioning, and it was sustained for 1 year's period, not only dramatic change in 3 months, but it sustained until 12 months. Next. But we have slightly different story in AUD. It's slightly it's decreased significantly between baseline to midline, but it was not sustained. After midline, it went off again. Many of those they were receiving care, they started receiving drinking alcohol. So this has been seen in both symptom severity and functioning. Yes, of course, we had a lot of challenges while implementing district mental health care package, but we had also a lot of facilitating factors. The first important facilitating factor, which I have not included here, is the motivation of health workers. They are quite motivated to learn mental health. The second, there was no focal person in Ministry of Health at that time, but we had a MOU with Ministry of Health, and Ministry of Health allocated, assigned one senior level person to coordinate PRIME activities, which was the biggest important facilitating factors. Similarly, another important point was frequent transfer of trained health worker. And when there is a new government, every 6 or 9 months we had a new government, there was a transfer of health worker. Then we had to conduct a lot of training. And the psychotropic medicine was the biggest challenge. When we started PRIME, there was no medicine and free drug list. Initially, we paid 6 medicine, but later on now this medicine has been included in the government free drug list. They are available everywhere free of cost. And another important factor that has been already discussed a lot about the supervision. There was no supervision system in the government health care system in the mental health. We created a supervision that is called psychiatrist case conference, where we invited health worker in one place and they discuss about their challenges and difficulty in front of the mental health expert, and sometimes they also brought some cases and there was a live discussion. These were the most appreciated and most liked intervention by the health worker. Thank you. Finally, I want to acknowledge my supervisors and also funders. Thank you.
Thank you very much, Nagendra. Nagendra is a bit of an endangered species. He's a male PhD student. So next up, next up is soon to be Dr. Medhin Salamu, who's just doing her revisions for her PhD. You saw the picture of her defense. So she's going to speak to us about burnout in primary care workers.
Okay. My name is Medhin Salamu, and my background is sociology, nursing, and social work. I'm working for Prime Ethiopia as intervention coordinator, and my dissertation project was on burnout among rural primary care workers. As we all know, there is a shortage of healthcare workers all over the world, which is critical in sub-Saharan Africa. And for example, if we take the case of Ethiopia, the number is much lower than the minimum recommendation made by the WHO. And this can lead the healthcare workers to face high workload, which is not compensated by adequate wage, and this can lead to low socio-economic status in the community, and they also face poor social system. This makes them vulnerable to experience job-related well-being problems such as burnout. And the objective of my dissertation was divided into 3 overlapping and highly linked study components. And this study was conducted in the Prime implementation site called SODO, and the participants were all primary care workers. That includes community-based and facility-based healthcare workers. And in the first study, what we did was, its objective was to explore the conceptualization of job-related stress, burnout, and well-being. And this was a qualitative study. And the second part was aimed at determining the magnitude of the problem. This was a mixed method study. First, we did the quantitative, and then to substantiate the results, we did additional qualitative study. And in the final part, we followed up all the study to participants, and our aim was to determine the short-term change of the level of burnout, as well as to evaluate the impact of integrating mental health service in the study site. And what we found out in the conceptualization study was participants commonly face job-related stress and experience some features of burnout, even though the participants' explanation of burnout is not typical to the textbook. For example, the description given by Christina Maslach and her colleagues is a 3-dimensional concept of burnout that's characterized by emotional exhaustion, cynicism, and reduced feeling of personal accomplishment. But even though it's not totally similar, they were able to describe burnout. And most of the time, I can say almost all participants externalize the experience of burnout. Instead of sharing their experience, they were sharing that it is a problem of other professionals, and they labeled this group of professionals as chronic member of staff. And next. And in study 2 and 3, we found out that the prevalence of emotional exhaustion is 7.7, which is a bit lower than what we have anticipated, but the experience is higher among community-based healthcare workers, and reduced personal accomplishment was also experienced by 43.7, which is similar to other similar settings. And during the 6 months follow-up, we didn't see any significant change in the burnout score. And from these results, we can conclude that burnout is an important issue, particularly for the community-based healthcare workers who are serving the major part of the population in low-income countries. And even though the prevalence of burnout is lower, some intervention need to be set, and this intervention need to give priority to the community-based healthcare workers. And the final and the essential conclusion we got from this research is there is no observable negative impact on the healthcare workers' well-being, or particularly on the burnout score of those healthcare workers that is resulted from the integration of mental health care service. Thank you all.
Thanks very much, Metin. And I think Metin started off thinking that delivering integrated mental health care would actually improve primary care worker well-being, so that didn't happen either. Right, now over to Tasneem Kathri, who's been working at the University of KwaZulu-Natal.
Yes, good afternoon, everybody. So my name is Tasneem Kathri, and my background is in psychology. I have a master's degree in psychology. And my PhD study is addressing the treatment gap for perinatal depression within an integrated primary healthcare model. And it's a psychosocial intervention for depression in the perinatal population in the Dr. Kenneth Kaunda district. I'm also the Prime Essay Coordinator based at the University of KwaZulu-Natal. So the study is divided into 3 phases, and each phase has a corresponding objective and a publication related to that. So in the first phase, our objective was a qualitative investigation of mental health care needs of perinatal women with depression in Dr. KK. And we conducted service user and service provider interviews. We looked at explanatory models of illness, and we explored pathways to care for perinatal depression. Slide. So in phase 2, our objective was to co-develop a package of care for women with perinatal depression attending primary health care services. And we did this by co-developing a collaborative care model with the sub-district. So this included sub-district health stakeholders, including mental health, maternal health, and primary health care stakeholders. And that is reported in a publication currently at the bottom under review. So at the focal point of this task-shared collaborative care model is the nurse clinician who does the consultations for antenatal, postnatal patients, screens for depression using a short depression screening tool, and patients who screen positive for depression go on to have the basic antenatal care. Well, actually all patients go on to have the basic antenatal care package, which is the guideline for antenatal care in South Africa. But those who screen positive then also have an assessment with the adult primary care guideline. And the reason for this is that there is a total absence of mental health assessment guidelines in the basic antenatal care pack. Women with mild depression are referred to the facility-based behavioral change counselor, and women with moderate to severe depression are referred to the PHC doctor upwards, or to the psychologist, as well as for suicide referrals, for initiation of antidepressants, and also to the facility-based behavioral change counselor for psychoeducation, and if they choose the 8-session program. And then all patients are then reassessed by the nurse once they've completed their 8 sessions, or however many sessions. So in the third phase, the objective was to evaluate the feasibility and the potential of this task-shared collaborative care model. looking at reduction in depressive symptoms and to improve functionality in others with perinatal depression who are referred for counseling or any other treatment in the collaborative care plan. So we conducted a pre and post-course experimental design. We did a baseline interview with screening and confirmation of depression and a 4-month follow-up. So in both the perinatal group and in the chronic care group, we identified common triggers of depression. And so for the perinatal population, we used an intervention that was already available in the facility and that the behavioral change counselor was trained in, which was the 8-session prime counseling intervention. We also did qualitative process interviews with service users and service providers, and we will report that in a 3rd publication, which is currently in draft. So just a little bit of information, the sample demographics, the women were between the ages of 18 to 35 years old and antenatal and postnatal patients. And our results indicated that there was a greater change in the treatment group, which was clinically significant versus the control group. And also in the internalized stigma, the ISMI, also a greater change in the treatment group. So our qualitative results showed that this was a very acceptable intervention for both service users and service providers. Service users indicated that the treatment was acceptable. The nurses and other service providers indicated that the screening and referral process was acceptable. The one thing that nurses were reluctant to do in the collaborative care plan was to refer upwards to the doctors and specialists. And this was simply because they perceived that there would be a very long delay in patients receiving that consultation, because for a PHC doctor, the patient would have to wait for about a week and perhaps a bit more for the psychologist. And some reluctance to use the adult primary care manual as well. So the recommendations are that we would have to perhaps look at adapting the basic antenatal care guideline, because that is the guideline that's being used for maternal and child health, and to include screening and a diagnostic guide for perinatal depression. One would have to add mental health indicators, set screening and referred targets, include a social worker as a resource within the collaborative care plan, and provide appropriate training and support and supervision for nurses, counselors, and actually all service providers in that collaborative care plan.
Thank you, Tasneem. And last but by no means least is Dr. Erica Breuer. Erica has defended her PhD. Somehow she did that, all while very ably leading Prime through as being project coordinator. So over to you, Erica.
Thank you. So as Charlotte said, my name is Erica Breuer. I have a background in physiotherapy. I became very interested in how to change services using evidence, and went and did a Master of Public Health and kind of fell into mental health work, and was lucky enough to get a job as the project manager for a new project that was starting up called the Program for Improving Mental Health Care at the University of Cape Town. That was in 2011. It's been a long time since then. and then did my PhD as well. So my PhD is looking at using theory of change, and Crick talked about theory of change earlier, to design and evaluate mental health interventions in low resource settings, and using Prime as a case example, and trying to learn some of the lessons from Prime that could be used for other complex health interventions. So what is theory of change? Well, theory of change is it comes from evaluation and sort of social science, and it's part of the evaluation approach is called theory-driven evaluation, and it's an outcomes-based approach which really maps out the causal pathways of how you expect a program to lead to impact. So the impact of Prime was improved health, social, and economic outcomes for people living with priority disorders, so depression, alcohol use disorder, psychosis, and epilepsy in some areas, and their carers or families in the district. And this is the prime theory of change. I'm not going to go into it, but this maps out how we thought prime would lead to a change in outcomes across actually all 5 countries. And as Crick said, every country had their own theory of change as well. So the PhD aims and objectives were sort of alongside the process of the theory of change within prime, which was happening. My first objective was to critically evaluate the literature on theory of change and public health interventions. The second one was to describe and compare the process of theory of change workshops and for conducting theories of change. The theory of change workshops are participatory workshops which are used to help develop the theory of change. And we conducted 13 of those across the 5 countries in prime, plus a cross-country workshop as well. To critically evaluate the role of theory of change and to present and describe a theory of change for integrated mental health care into primary health care. And then as well to conduct an integrated analysis of the process and outcome indicators for part of the theory of change in one country, which was Nepal. So the results. So theory of change is not new in terms of being used in the research environment and in public health. But when we did a systematic review, although we found 62 papers that have reported either how to design a theory of change for public health intervention or how to use it in the design and evaluation of an intervention, we found that actually it's not very well reported on. People sometimes just say, we use theory of change, but they don't explain what it is, why they used it, or how it improved what they did. So the second finding that we found was that theory of change workshops can really help to develop logical theory of change map, which provides, as we said, this pathway that leads to impact, as well as to help contextualize the mental health care plans. So when we conducted the workshops in every country, there was a lot of dialogue with stakeholders, from community health workers all the way to national level representatives about how the plans might work. So I know in Nepal, for example, there was a lot of discussion about how to actually get medication into the district and how to do that in the meantime while they were waiting for the government to take over. And the last one is really to co-develop the mental health care plan with the stakeholders. Another finding was that theory of change can be developed across contexts and can be used as a sort of map to also map out the evaluation of the different components of the mental health care plan across the different contexts. And it provided a very useful framework to evaluate across different settings, despite the fact that the interventions were context-specific. The fourth one was that qualitative comparative analysis, which is an approach which is used, it comes from comparative case study methods, and is a way of using Boolean algebra to compare and find patterns across cases, can be used with theory of change to combine process and outcome indicators. And lastly, which is very encouragingly, we found that supply and demand side interventions are both important to increase mental health service utilization in Nepal. And it's very similar to what Mark was talking about the results of what they found as well, is that demand side interventions are very important. So in terms of recommendations, theory of change can be useful when interventions are complex. But just be careful. It's a great tool, but there are some pitfalls, and one of them could be over-specifying the evaluation. And so it's important to make sure, once you've mapped out your theory of change, to still think about carefully what you need to measure. The other one is that theory of change should remain flexible, and it should be a tool that can be used flexibly by researchers to map out their causal pathway of their program, but to not get too hung up on that it has to happen in a specific way, and rather be used and changed as needed by researchers. And the last point is that we need more examples of how to really combine process and outcome indicators using theory of change. So there's some interesting work being done in structural equation modeling. We need to think about how to especially capture some of that complexity that we've collected with the process indicators, and we're working on that at the moment. Okay, so in terms of the next steps, and what the PhD has taught me, the one has been really that drawing lessons from other disciplines. What I mean by that is especially the evaluation and social sciences, and bringing that to public health. Similarly, this qualitative comparative analysis approach that we then used and applied to theory of change, which I don't think had been done before. Also working between the local and the global, so being able to look across contexts but also drill down was a really difficult and important thing to grapple with. And also I feel like I worked at the forefront of global mental health research, and it's been wonderful, and a wonderful 8 years to work with many of the people in this room. And maybe because I'm the last person, I'm going to finish off with something. I think my plan for personally is to continue working in complex health interventions, both within and without global mental health. But I just want to say that personally it's been a really great experience, and have felt very mentored by the people in this room, and have learned by watching other people lead with fairness and respect. 6 years ago, one of the colleagues in this room said to me over lunch at one of the meetings, it's very hard in global health and research to find people who are both kind and very good at what they do. And I think 8 years on, I still feel like that's true for the Prime Group. So thank you.
So that looks a bit like a bit of a setup, doesn't it? Can I invite all of the PhD students just to come to the front? And we've literally got just time for maybe 5 questions maximum. So if you can be thinking of your questions. Right. Any questions for the students? Not all of them are students, eh? Yeah. Anybody like any more information? No.
Thank you for the presentation, so inspiring. Erica, you ended by saying you might explain global mental health, and as someone who was global mental health over and viewed global health, I wanted to ask the other panelists if they felt that the skills that they've learned through working in crime will maybe mean that they branch out. I think what global mental health is developed as a discipline is quite special. Now I've seen what the rest of global health is like. And I wonder, I think there's some love that can be shared with other parts of global health. I wonder if you're thinking of stretching your wings further.
Yeah. Do you want to respond? Any thoughts? No? Erica, do you want to?
Yeah, I think it's really interesting to see what we've done in global mental health, and I think a lot of the time we've really dealt with a lot of, maybe not challenges that other areas of global health don't respond to, but I think there's a lot of perception around like contextual differences and how we had a lot of awareness of really how context really change what we do, and especially because of the cultural differences in how mental illness is perceived. So I think that understanding of context and really being very aware of it across everything that we did was something that I think can translate really well into other aspects of global health, which maybe isn't taken into as much account because by medical, sort of the more medical stuff is maybe seen as a bit more acontextual than mental health.
Sorry, Mary, could you repeat the question, please?
Oh, gosh. Are you going to stay global mental health, or do you think you might branch out further to other global health areas?
I certainly think there is a future in global mental health, but there is also a need for other things to come up. For example, there was a talk about implementation science. I think there is like a big opportunity for us to be looking at that. Also, I'm really interested in looking at what packages are available for technical support and how that can be tailored to the different needs in different places where implementation of psychosocial interventions are taking place.
I just want to add, I agree with Erika, there's a lot of complexities, and especially when we talk about the psychological intervention. I think this is also the beauty of this field, So even not across country, within the country also, if we consider Nepal, we have more than 125 caste ethnic group, more than 100 language. So it's really challenging to really work with those communities. Sometimes the terminology, if we work in one caste ethnic group, does not work another. But it's interesting field. So there's a lot to do. So we are encouraged.
I guess it's also how global mental health is defined. And there's been lots of literature over the years that, we've seen a growth on what's considered appropriate and what we've been working on. And like working within Prime with the different settings, there's definitely been for me personally, there's been a particular view of what global mental health is and how we ought to approach it, and the multiple contexts and the multicultural parts of it are definitely features that come with the package. So it's in that respect that I'm saying there is a future for that.
I'm going to ask Metin and Tasneem as well in lieu of further questions. Do you want to? Metin's already out of global mental health, really. You're on the edge, yeah? So are you going to come further into the fold, or?
I mean, I am interested in mental health, and that's global mental health, but specifically in job-related well-being and burnout and stress. It's more of a preventive. I think, in my opinion, it focuses on health promotion or mental health promotion, and that's my area of interest.
So I would say that global mental health has some wonderful lessons, and I think definitely in Prime we have learned some amazing things across the countries. And I think these are good lessons to transfer into global health. And I would also ask, in the interests of integration, should we not be thinking about global health instead of global mental health and global health separately? These two different concepts. I think it should be global health.
Yeah. Great. Okay, one last burning question, and then we'll.
Can I answer? And then maybe you add. I think there were two sort of groups of PhD students within Prime. There were the people, we all work for Prime. So we actually met a lot, and there was a lot of communication between us at meetings. We've reviewed each other's papers informally. So I think there was a lot there. And I think there was this very strong, and most of the other PhD students were in Ethiopia, and I think maybe Metin can talk to that as well.
In our experiences, we didn't meet as a Prime PhD students, but we had a chance to work together, and what was a great opportunity for me is I think I was somehow privileged to get in touch with my supervisors quite often, and I used to get advised whenever something arises, and when I need something, it was much easier for me to get help as compared to the other students. So it was a great platform.
I just want to add one more, like Erika says, we did not have that much formal meeting to discuss our PhD, but we had a lot of opportunity. For example, we are here in London for the last couple of days, and we'll be staying a few more days. Then when we have time, we used to chat, and that's one thing. And another thing, we are also some of us are in the co-author in the same paper, so that's another platform. So it's a lot of advantages to be a first prime cohort PhD.
Many of our studies are informed by similar designs across the different contexts. So perhaps that's one of the reasons why there's a similar thread across the different studies. It's many of them are of material that we all worked together on.
Mm-hmm. Great. Well, I think we're going to wrap up now. So if anybody would like, of course, to get sort of further detailed content information from each of the students, I'm sure they'd be delighted to discuss over lunch. So just one round of applause for them. Thank you. And I'm just going to hand over to Crick to close the meeting, off mic probably. You got one.
Okay, thank you very much. Thanks everyone for staying the distance and for being here to hear all the work that we've been doing over the last 8 years. It's been a fantastic experience, and we look forward to speaking more over lunch. I just wanted to, there's an enormous number of people I could thank, but I just wanted to particularly thank Machi Marks, who's done a huge amount of work to get this event together. She's our research uptaker and officer in Prime, and it's been a wonderful feature of Prime to have a full-time research uptake officer who can disseminate materials and engage with the public. So thank you. Enjoy your lunch. Thank you.